Dwight, come here a minute. Dwight, come here a minute, please. Because I don't even know if I on mute or
Good morning.
It's not muted. That I haven't started yet. Right, what it says, it's not muted. Have they muted? No.
click on the
Is he speaking or that?
He's speaking.
Good morning. We shall be starting.
Full screen.
Thank you.
Morning, good morning. Welcome you all to our dementia conference workshop, they say. It has been long in planning. We had wanted to do it in April. Then we went to May and June. We are July here. There's been a lot of work by the executive CCFP, Jamaica chapter. And finally, we are here today. We thank God for that. We're going to start. I'm Dr. William Brown, past president of the CCFP Jamaica chapter. I'm going to ask our present president, Dr. Nonoju, to come and say welcome, and then a prayer by Pauline Williams Green, who is online. Dr. Nonoju, you can come.
Or drink, even if you have to water. Just see patients back to back. Or you see try to take a patient's history because you can't stay away no matter how working it's uncomfortable. Interaction with each patient.
Good morning. Morning. Morning.
Prayers.
Our specially invited guests,
Prayers.
esteemed colleagues, friends, ladies and gentlemen, good morning again. As your newly elected president, I start by thanking all of you for giving me the opportunity of service to you and for having the confidence in me to carry out such an important task. With your help, support, and guidance from my predecessor, I pledge to do my best to carry out my responsibility as the president of the Caribbean College of Public Physicians, Jamaica chapter. Today's workshop will be on dementia, the public health priority. Dementia is a global epidemic affecting persons from both high-income countries as well as low and middle income. The number of people living with dementia worldwide in 2015 was estimated at 47.5.
Can the moderator please mute all the mics that are not presenting, please?
And 135.5 million in 2050. Population aging is the main driver of projected increases. The impact of dementia is quite significant, with dementia and cognitive impairment being the leading chronic
Sorry,
disease
Dr. Seni, Dr. Seni, we can't hear you. Somebody needs to mute everybody else.
People worldwide.
Functioning like
Older people, while older people can often cope well and remain reasonably independent, even with marked physical disability. The onset of cognitive impairment associated with dementia quickly compromises their ability to carry out complex but essential tasks in their daily lives.
I hope you can understand what that means. Between 4 p.m. and 8 a.m. the next morning, we would get between 40 to 50 patients. This includes children and adults. It does not end there.
For support from a caregiver often starts early in the dementia journey. It intensifies as the illness progresses over time and continues until the global economic impact of dementia is also quite significant, with the total estimated worldwide cost of dementia being US $604 billion in 2010, equivalent to 1% of the world's gross domestic product at that time. The future scale of dementia epidemic can be reduced through improvements in population health. Also, there is an urgent need to develop cost-effective packages of medical and social care that meet the needs of people living with dementia and their caregivers across the course of the illness, along with evidence-based prevention strategies. In concluding, it is not surprising that the Caribbean College of Family Physicians, Jamaica chapter, saw it necessary to highlight this important topic through this workshop with the hope of raising awareness and improving attitude and management among healthcare professionals and caregivers of persons living with dementia. To this end, we have a lineup of interesting presentations and great presenters who bring a wealth of knowledge and experience in the field of dementia. Once again, I welcome you all to this very important workshop, and I thank you. As is customary, we love to call on the power of the Almighty to be with us and guide us throughout the proceedings. Without further ado, I now invite Dr. Pauline Williams-Green to lead us in prayer. So, Dr. Green.
Thank you very much, Dr. Onanuju. May I invite you all to mute your microphones if they are not on.
Pauline?
Yes?
Pauline,
can you hear me?
So early?
Yes.
Pauline
yes,
Williams-Green?
I'm here.
Don't hear you.
You can't hear me?
Volume. Again?
Can you hear me now?
I can't hear her.
Oh, hold on a second.
I am trying
Pauline,
to
hold your prayers.
I hope everyone can hear me now.
Pauline, you can hear me? Hold your prayers.
Can you? Okay, I've unmuted. Can you all hear me now?
Turn on your Pauline, you can hear us?
Very well. I can hear you very well. And the others say they can hear me.
Okay, 1 second, hold on.
They can hear me.
No, hold on.
It's the hub that's not hearing me.
Pauline, thank you. We can hear you now. Thank you very much. Yeah, you can start your prayers now. We're ready.
I'll be brief. Let us pray.
Yes.
Thank God for all present in person and online via Zoom. Help us to learn from the presenters and from each other. Heal us, physicians too, and guide us to apply our healing skills to all who seek our help. Bless our leaders in their actions to be just and protect the vulnerable. Thank you, O Lord. Amen.
Amen. Thank you very much, Pauline. The absence of your program, there is a sponsor's presentation. Absence of the sponsor's presentation, I would like to fill the gap by doing what I usually do. One thing I've learned from COVID is advancement, things that we could have done and we weren't doing. And now we've been forced to go online with everything. Even my gardener and my helper, I pay them online now. We save a lot of gas. But we are here this morning, and you know, if my body was a car, this is the time I will be thinking about trading it for a newer model. I've got bumps and dents and scratches in my finish, and my paint job is getting a little dull. But that's not the worst of it. My headlights are out of focus, getting older, and it's especially hard to see things up close. My traction is not as graceful as it was once. I slip and slide and skid and bump into things, even in the best of weather. My white walls are stained with varicose veins. It takes me hours to reach my maximum speed. My fuel rate burns inefficiently. But here's the worst of it. Every time I sneeze, cough, or sputter, either my radiator leaks or my exhaust backfires. This is my little joke for the morning. So, ladies and gentlemen, we're going to go straight ahead. Why dementia risk reduction is important for general practice. Many people, especially those with a family history of dementia, I was told we can't put the mask on our necks because we're transporting germ from the neck to the nostril, so I prefer to do it this way. Hold it on the side. Many people, especially those with a family history of dementia, are interested in what they can do to prevent developing the illness themselves. GPs can assist patients by providing advice about the lifestyle and health factors that are consistently associated with the risk of developing dementia. They can use recommended preventative health interventions to reduce the impact of modifiable risk factors for patients. We shall see this in the second presentation, how to manipulate these modifiable risk factors for dementia. Now, since the incidence of dementia is growing rapidly, as Dr. Nutt pointed out, with the aging of the population worldwide, and currently there are so many, 270,000 places like Australia with dementia, and this is expected to increase exponentially by 2050. Now, while there's no cure for dementia, addressing modifiable risk factors remains important strategy for reducing the incidence of dementia. Modeling suggests that if the average onset age could be delayed by 5 years, incidence will be halved by 2050. Indeed, many people remain unaware of the potential of dementia risk reduction. Some associate mental activity with reduced risk, but very few acknowledge the important link between vascular risk factors and dementia. Now, GPs can help address this by educating patients about their risk factors, helping patients make appropriate lifestyle changes, and treating medical risk factors. Now, there's evidence that GPs can assist patients to make lifestyle changes aimed at reducing their risk of chronic disease. For example, brief clinical intervention by GPs have been shown to improve the success of patients' attempt to quit smoking and improve patients' levels of physical activity. Preventative health strategies aimed at maintaining cognitive health have the potential to have a significant impact on future members future numbers of people developing dementia, and GPs have an important role to play in this. So in short, what GPs can do, summarized in the 5 R's, and you can put them down. First is to reassure, that's to commend healthy habits and encourage the reluctant. 2, the second R is remind. Regularly educate patients about the benefits of brain healthy behavior. The third R is to review. Regularly check progress, especially for those at higher risk for dementia. The fourth R is refer. Refer to specialist services if risk factors are difficult to control. And finally, refresh. We need to refresh our knowledge regularly about dementia risk reduction strategies. So here we go. A 10-point question. Those who can answer, please do. It's a very short questions, 10 points, just to warm you up as doctor comes up. So the following modifiable factors which improve Alzheimer's disease, AD, risk include 1, true or false, alcohol. Is it true or false? They improve the disease risk. They improve alcohol. If you take alcohol, will it improve? True or false? No. Blood pressure. If you control blood pressure, will it improve it? Yes. Body weight. Obese person? Yes. Cholesterol. If you control your cholesterol, can? Yes. Depression. If you are depressed, what? More likely that you get Alzheimer's. Diabetes. True or false? True. It will worsen it. Head injury. If you improve your mental activity, then you improve, right? You reduce the risk factors. Physical activity will improve it. Smoking, you can get it more. Social activity, good, right? Social status, true or false? Your social status, whether a chairman or president or prime minister, will improve or worsen the risk. Yeah? It improve it or it depends? It depends on what? Or the individual. You explain that to us, President, later. Finally, sexual activity. Sexual activity improve it? You'll explain that to us, Doc. Number 2, autosomal dominant gene mutations usually result in younger onset dementia diagnosed before 65 years of age. I repeat. Is it true or false that autosomal dominant gene mutations usually result in younger onset dementia diagnosed before 65 years of age? Is it true or false? Autosomal, family history, yes. So if you are diagnosed with autosomal dominant gene and there's a mutation there, then you are likely to be diagnosed with dementia before the age of 65. Number 3, having a family history of dementia is associated with an increased risk. That is true. Now, those with a first-degree relative having Alzheimer's disease have a 10-fold increased risk of developing the disease themselves. True or false? 10-fold. False. What's the actual ratio? 2 to 3 times. Good. Not 10-fold. In old age, those who are underweight or are losing weight are found to be at increased risk of dementia. True or false? Those who are losing weight or underweight are found to be at increased risk of dementia. True or false? True. True. Cholinesterase inhibitors have shown modest benefits in cognitive, functional, and behavioral domains for patients with AD, Alzheimer's disease, and reduce caregiver time and distress. True or false? Cholinesterase inhibitors, medication that we use for Alzheimer's, the symptoms. Is it true or false? True. In patients with severe dementia, behavioral disorders can respond well to psychosocial approaches, such as behavior modification, music therapy, aromatherapy, exercise and activity programs. True or false? True. Last 3. Dementia is a syndrome characterized by a decline in memory and at least 3 other symptoms that affect cognitive ability and is severe enough to cause a significant impairment of social or occupational function. True or false? True. Modifiable risk factors include the potentially protective effects of a high antioxidant, true or false, of statin therapy, true or false, statin, exercise, true or false, higher education, true or false, true. The prevalence of Alzheimer's disease is higher in males versus females, true or false, false. And the prevalence of vascular dementia is higher in males versus females, true or false? True, in males, vascular dementia, all right? So these are just to warm you up as I introduce Dr. Barnaby, who has a very interesting and summarized resume here. And so when you hear me talking about stride, it's not I'm taking a stride in anything. We talk about SOCI. It's not because I'm a sociopath. We talk about things like NAG, not because I want to nag you, but I just want you to remember. And these are some of the things I'll be using in introduction. So it's a JP, DM Psych, UE, MPH Hans, Yale, FAPA. So our first presenter, Dr. Lorraine Barnaby, is a Jamaican medical doctor, specializing in psychiatry, and is a consultant psychiatrist and international fellow of the American Psychiatric Association. I think that's the FAPA, fellow of the American Psychiatric Association. She received her undergraduate in psychiatric training at the UE and completed her master's MPH with honors at Yale University, New Haven, US, while on a Kellogg fellowship. Professionally, Dr. Barnaby has worked with a wide variety of settings, disciplines, and countries, most recently in the Cayman Islands, but also in the past in the Bahamas. She was a member of the visiting faculty of CARIAD, the Caribbean Institute for Alcoholism and Drugs, and as a short-term consultant with PAHO, WHO, UNESCO, etc., in several Caribbean territories. These consultancies were predominantly in the area of substance abuse, but also in HIV education and community psychiatry. Now, let's focus on the work in dementia that we are interested in today. Dr. Barnaby worked at UHWI in the first dementia clinic in the island. Interesting. Maybe clap her. Worked at the first dementia clinic in the island. She's currently a part of the STRIDE group, researching aspects of dementia. Still, for several years, she was a board member of the Alliance on Aging here in Jamaica. In Cayman, she was a board member of the ADACI, Alzheimer's and Dementia Association with the Cayman Islands. She currently is a member of the National Advisory Group of the STRIDE team. The team is based at the Faculty of Medical Sciences, Mona Campus, which is part of an international multi-center study of dementia. Interesting. The aims of STRIDE vis-a-vis the NAG, the National Advisory Group, NAG to NAG, is to sensitize NAG to the importance of dementia research, to sensitize NAG on its role within the wider STRIDE project's governance, is to update NAG on the expected impact, outcomes, and interventions of the project, and to provide an overview of STRIDE JA work packages, and to discuss with the NAG how members can support and guide its work. Dr. is or has been a member of several other international associations, including the IPA, AAGP, etc., etc., etc. Outside of work, what does she do? Dr. Barnaby is a past president of the Soroptimist International Jamaica and Kingston Service Club. She's a Special Olympics athlete coach, really, and served on the board of the Special Olympics Cayman Islands, that's the SOCI. An Anglican by faith, Dr. Barnaby attends the Church of the Ascension, Mona Heights, and she's the chair of the medical clinic there, where clinics are held every Wednesday from 4 to 6 p.m. Ladies and gentlemen, it's now our time to invite Dr. Barnaby to look at dementia overview, types, how to recognize and make the diagnosis of dementia and Alzheimer's disease, and the latest trends that she has noted thereof seen. So will you please help me welcoming Dr. Barnaby to the podium? Thank you.
Thank you very much. And it seems to me that you already know a lot about dementia and Alzheimer's disease, and that's to your credit. Now, I want to thank the organizers very much for their kindness in inviting me to make this presentation. I trust that it will be helpful to you, and I urge you all, as I go through some of the tests that we use, that you will in fact find use some of those, because you can use them in the office, you know, they're not hard to administer. So I start by reminding us that in 2019 there was a report from the Alzheimer's Disease International looking at attitudes and beliefs about dementia. And this study actually was of about 77,000 persons globally, 155 countries. And they looked at, well, in fact, the study found that 2/3 of the persons in the general population felt that dementia was part of normal aging. And the health practitioners who were also surveyed, 62% of them felt the same. Now, I know that doesn't apply to you because we do not recognize that senility is something which is normal. And to illustrate this, I have a short video which I'd like to show you before we get into the meat of this talk. Now I need to get my video up. And I am grateful for the help I'm getting from the persons here. Now this video is talking about unveiling the mystery of Alzheimer's, and it looks at, okay, I think we will be able to proceed now. And you will tell me whether you're seeing my video. Are you seeing it now?
It's still loading. Inside
the brain, unraveling the mystery of Alzheimer's disease. It's an American video from the National Institute of Aging.
The human brain is a remarkable organ. Complex chemical and electrical processes take place within our brains that let us speak, move, see, remember, feel emotions, and make decisions. Inside a normal, healthy brain, billions of cells called neurons constantly communicate with one another. They receive messages from each other as electrical charges travel down the axon to the end of the neuron. The electrical charges release chemical messengers called neurotransmitters. The transmitters move across microscopic gaps or synapses between neurons. They bind to receptor sites on the dendrites of the next neuron. This cellular circuitry enables communication within the brain. Healthy neurotransmission is important for the brain to function well. Alzheimer's disease disrupts this intricate interplay. By compromising the ability of neurons to communicate with one another, the disease over time destroys memory and thinking skills. Scientific research has revealed some of the brain changes that take place in Alzheimer's disease. Abnormal structures called beta amyloid plaques and neurofibrillary tangles are classic biological hallmarks of the disease. Plaques form when specific proteins in the neuron's cell membrane are processed differently. Normally, an enzyme called alpha secretase snips amyloid precursor protein, or APP, releasing a fragment. A second enzyme, gamma secretase, also snips APP in another place. These released fragments are thought to benefit neurons. In Alzheimer's disease, The first cut is made most often by another enzyme, beta secretase. That, combined with the cut made by gamma secretase, results in the release of short fragments of APP called beta amyloid. When these fragments clump together, they become toxic and interfere with the function of neurons. As more fragments are added, these oligomers increase in size and become insoluble, eventually forming beta amyloid plaques. Neurofibrillary tangles are made when a protein called tau is modified. In normal brain cells, tau stabilizes structures critical to the cell's internal transport system. Nutrients and other cellular cargo are carried up and down the structures called microtubules to all parts of the neuron. In Alzheimer's disease, abnormal tau separates from the microtubules, causing them to fall apart. Strands of this tau combine to form tangles inside the neuron, disabling the transport system and destroying the cell. Neurons in certain brain regions disconnect from each other and eventually die, causing memory loss. As these processes continue, the brain shrinks and loses function. We now know a great deal about changes that take place in the brain with Alzheimer's disease, but there is still much to learn. What other changes are taking place in the aging brain and its cells? And what influence do other diseases, genetics, and lifestyle factors have on the risk of developing Alzheimer's disease as the brain and body age? Scientific research is helping to unravel the mystery of Alzheimer's and related brain disorders. As we learn more, researchers move ever closer to discovering ways to treat and ultimately prevent this devastating fatal disease.
Okay, so there you got a capsule of the Alzheimer's disease process. Now we're going to go on to the actual presentation, and I trust that if you feel that you must interrupt me for something, that you will do so.
You need to share the screen for this.
Okay, ladies and gentlemen, this is a kind of plan of presentation, so I'll move swiftly on. And we talked about the report already, and the only thing I'd say to you is that, in addition, is that every 3 seconds, somebody in the globe gets a diagnosis of Alzheimer's disease. Now, the attitudes of the healthcare practitioners, I wanted to highlight a little bit. And they're talking about how people kind of ignore the ill one and talk to the well one, okay? So these are two reports. My neurologist ignored my presence when my diagnosis was discussed with my husband. And second one said, neurologist diagnosed me with Alzheimer's at age 56 and then told me to go home and get my final affairs in order and wait for my premature death. Sounds pretty terrible, eh? And I trust that none of us would deal with our patients in that manner. No, this is just to highlight that there have been a few Jamaican studies really looking at some of the things that are risk factors for the Alzheimer's and for dementia. People like Dr. Tully Reed and people like, well, there's a whole set of people. This is just to titillate your fancies. You can find these things in the West Indian Medical Journal and other places, okay? No, we had only one study of the dementia clinic, which was done between 2001 and 2005. And I didn't bother to put it on because that's now kind of way back in time. And the main thing that it showed was that diabetes and hypertension were very, very common among the population that we saw. We actually saw more males than females, although the prevailing idea globally is that women are more liable to be diagnosed, and it's partly because women live longer than men. That's part of the reason why that is so. Now, I want us to just quickly go through a definition of dementia and a couple other things, and then I want us to continue on. So my definition is from the Dr. Pasternak at University of Waterloo. And he says, one, a global impairment of mental function, which follows a chronic and progressive course. The deterioration of intellectual capabilities, memory, judgment, and personality to the extent that daily functioning and the quality of life are seriously impaired. Now, when you look at that particular definition, immediately you can jump to the notion that Alzheimer's itself fits in here. And in fact, the term dementia is an umbrella term that encompasses the most common form of dementia, which is Alzheimer's disease, as well as other things. Now, cognition is one of the terms that we use a lot, and it implies brain processes involved in thinking, learning, and memory and understanding, judging, and remembering. The frontal lobes of the cerebral cortex of the brain are mostly involved. Another term, executive functioning, which refers to some of the activities that we normally do and take for granted with our brains. Planning, sequencing, abstraction, and organization. And finally, ADLs. We're talking about activities of daily living. Things that we do all the time. We surely bathe and we dress and we eat and we put on our clothes and we drive around or walk around. These are ADLs or activities of daily living. Now, I think I'm skipping a slide. Okay. Apart from Alzheimer's, there are some other kinds of dementia. And these are some of the ones that were being discussed and questions were being asked about some of them earlier. This disease, also called frontotemporal dementia, Creutzfeldt-Jakob disease, which is the one that is caused by prion. You've heard of that one. Huntington's chorea, which is one of these autosomal dominant ones. Down syndrome, trisomy 21, in fact, which is a very important one, looking at the research to do with the dementia. Alcohol, various tumors, their primary or secondary, and dementia pugilistica, boxers get repeated concussions, and other persons too are not boxers, people who are involved in football and so on. They succumb to head trauma on the field. They can also develop in the long-term dementia. And various kinds of hematoma in the brain, subdural and other kinds of hematoma. Then we have a whole list of infections, encephalitis, abscess, and so on. GPI is general paresis of the insane, which is related to syphilis. Parkinson's disease, although Muhammad Ali, he was very slow as a result of the disease, but I don't know if a test of his memory and other things would have revealed of dementia. Epilepsy, metabolic disorders, including diabetes, thyroid disorders, whether it's hyper or hypo, and parathyroid disorders, vitamin deficiencies, and these include all of the things like B12, folic acid, and also thiamine is very important to do with alcohol when you're in cortical psychosis and other things, and various toxins. I'm going to just, there is a missing slide, but that I will just tell you That the missing slide includes things like the vascular dementias and the combinations of vascular dementia and Alzheimer's. But there is a distinction that can be made between the two, and it looks at how the things progress. Now, with the vascular, suppose you have a stroke, you will get a diminution of your abilities, and you see that then it's a plateau, then it goes down when you have another stroke, and so you have this stepwise progression. Whereas with the Alzheimer's, unless it is you're on some kind of treatment, it's a progressive decline until death. Now, you see the man on the left side there, that man is called Dr. Alzheimer. And he is the first person who discovered these plaques and tangles. His patient is in the middle. Her name is Augusta Dieter, German. She died, she had severe behavioral issues to do with it. She was paranoid, she had memory problems, and her behavior was erratic. So she died 5 years after Dr. Alzheimer saw her in 1906. And when she died, he did a post-mortem and looked at her brain, and he found these very strange and interesting things. And he presented it at the medical society. But, you know, for the older, not decades, nothing much happened. People weren't paying attention to this thing until, perhaps because of the development of things like the electron microscope and other things, it was possible now to look at these things and to see similarities histopathologically with other people who had these memory issues. All right, so the Alzheimer's is defined as a progressive brain disease in which there is gradual loss of short-term memory. And it's very important to say short-term because the hippocampus is that area of the brain which is involved in mediating the short-term memory. Anybody ever saw 50 First Dates? No, it's a movie, you see, with Adam Sandler. And this girl, she had a severe motor vehicle accident, and as a result of that, she had a dementia. And she couldn't remember anything. So every day, he came to see her, and it was like she was seeing him for the first time, 50 First Dates. It typically shows you what short-term memory loss is like. And if you are getting Alzheimer's, it's like what you have for breakfast. You create a little bit of turmoil in your head because you don't remember what you had for breakfast. Anyway, trouble finding or speaking the right word, inability to recognize objects, disorientation, especially from place. And things like forgetting how to use things, like what do you use a pen for? Or you see, if you actually recognize the pen, you say to yourself, I'm Alzheimer's, I have the Alzheimer's, and I'm saying, the thing that you write with, I can't get the word, so I say the thing that you write with, or the thing that you use to open the door for keys, and so on. They forget to turn off the stove, so they burn up a lot of things, they forget to lock doors, and sometimes they can't deal with self-care. We have early and late stages, and as the disease progresses, there's more and more decrease in their ability to self-care and to manage themselves. I'm going to show you some of the tools that we use to measure these things. There is a term called MCI, I'm not sure if it's coming up next, but I want you to look at MCI. These are some of the other causes here. I want you to look at that, and something is not right here. I'm going back. I want to go down. No, we all the way down. We want to go up, up. Sorry about that. We're trying to up. I want to get beginning. Yeah. Okay. This looks good. Yes. Yes. I want to get to that point where I can. Okay. Okay. Now, we talked about risk and protective factors. These are some known and possible risk factors, and there's some protective factors as well. So we know that increasing age is the most important risk factor. And it was mentioned that our populations are aging. I had a slide that dealt with Jamaica in 2018 and Jamaica in 2050. And the important thing there is that the pyramid, the population pyramid, changes as you have more and more older people in the population. It becomes more like a barrel instead of like a triangular pyramid. And this is the case here in Jamaica. The projection is like that. And especially in the Cayman Islands, where it's actually very, very much like a barrel already, but we're kind of still with a little bit of a peak. And so maybe that's a good thing. Genetics, there are a number of causes of the pre-senile dementia, the dementia that occurs before 65. And some of them are family related. But there are small groups of persons in the world who do have these genetically involved dementias. Down syndrome was already mentioned. We talked about head trauma, celiac, and vascular disease. And for the protective factors, we're looking at education, using NSAIDs and estrogen. I have a problem with the education aspect because I know many persons who are highly educated, you know, professors and whatever you can think of, researchers, and they have succumbed to Alzheimer's and died from it. And on the estrogen, I would say that you have to be very careful because the same estrogen can give you cancer. So very important. Okay. Now the main problem with this, apart from what we saw to do with the amyloid and you know the plaques and the tangles, acetylcholine is in short supply. Now, acetylcholine is one of the neurotransmitters which is very important for the brain, especially the frontal and the temporal aspects of the brain. And so, with this shortage of acetylcholine, which is caused by the enzymes which are connected to the breakdown of the like say, overacting, then you will get this problem. Plus, remember, cells are dying, brain cells are dying, and you saw how the brain looks really like a piece of art, and not like what it is supposed to look like. There are other transmitters which are involved in this thing, and the one I want to highlight today because of the drugs that we use is glutamate. Glutamate is more of a stimulatory transmitter, and so when we want to work with trying to control its work, we have to find something that's going to dampen that. Now, we talked about the early onset type, and we talked about the late onset type of dementia. We know about the amyloid precursor protein from our video, and we also are aware that there are two compounds, presenilin 1 and presenilin 2. Genes are found on chromosome 14 and 1 respectively. That's for the early onset type, and I use Down syndrome as a prototype for that. The late onset type has many genes connected to it, single genes. The important thing here is that we must be aware of the apple lipoproteins. Now, the E4 is one of several. We have alpha lipoprotein 2, 3, 4, and so on. And this one, where you have the E4, is the one where you get problems. Okay, so we can have the genes like we get E4 from mother and E4 from father, so you have 4, 4, and you get a problem. These are found on chromosome 19. And then this other enzyme, bleomycin hydrolase, on chromosome 12, and another gene on chromosome 10. Every day they find a new gene locus on a different chromosome. All right, this was a population pyramid for Jamaica. You see on my right side that if you look at it, you see that there's more women at the top than men. And you see, this is a 2050 projection, and the one on the left is 2018. Now, we had one from Cayman. As I said, it looks more like a barrel than Jamaica's population pyramid. Moving on. You diagnose this thing. It's very important to be able to diagnose it. And it is said that nowadays, it's not just exclusion that we use and or negative tests, but we can use clinical diagnosis. Okay, we can take a careful history from the patient and from the family of the patient. Now, of course, that presupposes that the family are in fact in contact with this person. You see, and sometimes they're living away from the person. Thorough physical examination to rule out any cause of the dementia that you could actually deal with. You can treat it and treat it effectively. A neurological examination, absolutely, to rule out things that could cause imbalances in power and reflexes, which again, more than likely you can intervene in them. You know, you can do something, whether it is to do with drugs or surgery or some other intervention, which could include psychiatric intervention. Laboratory tests, there are several of those to be done, and I have them on the next slide. Also, the importance of brain imaging, CT and MRI, and in other centers abroad, you can do functional MRI, which is very, very good to delineate the conditions. Screening tests, which I'd like to go through, you have the mini-mental status examination by Falstein, which is very good to detect aspects of brain functioning. Regular mental status examination, which I would do for a patient, using the geriatric depression scale to see whether there's any depression involved in this person's presentation, and the functional activities question. Okay, these are the list of investigations, and I will tell you that this list is a nice list. It is from the what do we call it? Let me just think about it forward. Maybe this is my senior moment. There's a thing called AIDS to postgraduate medicine. And in it, you see a section relating to neurology and to do with dementia and other brain problems, you see? And it has that list, which is a very nice list. Now, you see, I put ECG and spinal tap. ECG, remember there's vascular conditions, and you want to check that out. And also the spinal tap, because sometimes, well, I'm thinking there particularly of tau, which is a biomarker, and depending on the center that you're working in, you could actually do the MP, and you will be able to measure the tau protein level. Okay. I also would like to say to you that in regard to the CT scan, you can use the CT and also probably the functional MRI to the hippocampal volume, because you know that hippocampus will decrease in size as the disease progresses. And one other thing I want to just highlight, these changes that were shown in the video, they occur way before there are clinical manifestations, up to about 10 years before you can find these things in the brain. You know, so it means that it's a very serious thing. And it would be very good if we could be able to diagnose the condition before it manifests, and it would be even better if we could prevent the clinical manifestations, and we must look at that. Okay, now I wanted to just touch on MCI, because it's a term that we will have come across a lot, mild cognitive impairment, and really is talking about a condition. The person, say I'm the one with the Alzheimer's. I know that something is going wrong. I'm not as sharp as I was before. Sometimes I can't find my keys, and it's not one time or two times, it's many, many times. Or I find that I'm not doing well with recognizing people, you know. So this is part of it, but the person can actually do most of the other things. If you have to dress yourself, you can't put two legs into one pants leg. And when you do the testing, you don't really see any change at that point. Now, these are two references to do with that revised criteria for mild cognitive impairment. And in this, the first one by Morris, what he's saying is that because of the revised criteria, it means that MCI is now shaded into early Alzheimer's disease. And in fact, they're questioning whether MCI is a valid diagnosis, you know, to separate it out from early Alzheimer's disease. All right, we talked about the biomarkers, we talked about tau in CSF, and you know the function of the tau already to stabilize the microtubules. We saw those, you see. Microtubules are very important, they help with the nutrition of the cell and so on. Clock drawing test. You see that's okay, and you're going to ask the person to put in the numbers on the clock face. You're going to ask them to say a particular time. Usually we say 11:10 or 20:08. Okay, now remember, the clock does not have a 20 on it. Okay, so it requires for them to, oh, I think something is blocking the rest of it.
You're fine.
Okay. Yes. So there's no 20 on it. So if you have a problem with your mentation, with your cognition, and you get dementia, you may have an issue with where is 20. You see, although we know that 20 is the same as 4. Okay, so we ask them to do this. And then several, and how we score it, if it's a normal depiction of a clock, because you must put the numbers, you must put the hands in order to write the time, the 11:10 or the 8:20. Right? So once you have that, that is a score of 1. That is normal. If you don't get it, if you have some errors, like you put the wrong time, you don't put any hands on it, you put the numbers, that the numbers are going to space, or you repeat the thing, or you don't, if you refuse to do the test, it says that you are actually, you may have a problem because you don't want to disclose the fact that something is going on up there. Okay. The next one is really showing, I'm stuck here again. The next one is going to show you, I think, the mini mental state exam, the Falstein. The Falstein test looks at different aspects of cognition. It looks at memory, it looks at here we are. Mini mental status exam. This is what the form looks like on the left. Okay, but there are some slight variations in how the form looks. And so you look at all of these aspects as you go through. So let me now go through. I hope I can do it quickly. Orientation, what is the year, the season, the date, the day, and the month. We're trying to see if they're really keeping up with it. Okay. Right. Now, 5 points are possible because you're asking 5 different things. Okay. And suppose I had the Alzheimer's now. You know that today is the 19th of July, 2020, but I say to you, oh, March 1960, March the 10th, 1960. And I'm happy with that, and this is weight up. Okay? So I wouldn't get 9 marks, okay? Then here now, because this is a false state, it's an American state. Now I usually substitute a different word for state, okay? I ask them sometimes for the, like Cornwall, Middlesex, and Surrey, ask them for that. And I ask them for country. So, state is, let me tell you what I usually do. State is Jamaica. County is one of those counties. Cornwall, Middlesex, Surrey. City, wherever they are. And where are they located at the time? Usually in the clinic. And the clinic, my clinic was in the hospital. So if they said hospital, you're in hospital, or they said clinic, then I accept it. And what floor? Is it the ground floor or is it the second floor? If they tell me first floor and then second floor, it's still acceptable. Registration. You ask them to name 3 things, right? So you tell them the things. Suppose they said dog, and they repeat dog. And then I say chair. You repeat chair. You're the patient. You repeat chair. Sorry, chair. And if I had COVID, I'd be giving it to the night. So anybody else will? Sorry. And then I might say tree, and you think. So you ask them to repeat these for you, and then you give them another test to see if they will remember the 3 things as it registered on their brain. Okay. So, and you may have to keep on doing it until they remember, till they've learned the sequence. Okay, now you do serial 7s. You know serial 7s, right? So you start from 100 and you go down, all the way down, right? Which is 93, 86, and so forth. You go on to 65. You do 5 of them. If they can't do that, you ask them to spell word backwards. So it's what they're supposed to tell you is DLROW. Usually they give you backward W-R-L-D. Then you ask them to repeat the 3 things that you told them, right? So what are they? What did I ask you to remember a while ago? Dog, chair, and tree. You all have Alzheimer's. That's a joke. Language and praxis. You ask them, what is this? It's a pencil, okay? And you show them your watch, and they're supposed to name it, name the objects, okay? Remember, that's sometimes an issue, okay? And then you ask them to articulate no ifs, ands, or buts. There's another one that can be asked to, another set of phrases there. And if they can do it, then that's good. No problem with dysarthria. And then you ask them now to do this 3-stage command. You ask them to take a piece of paper, fold it in 2, drop it on the floor, and I usually add another part to it, and then hand it back to me. Okay? So that's, you can do 3 points if you do this one. If you add on and give it to me, that's 4 stages, and that's even better. Then you ask them to close their eyes and to write a sentence, not while their eyes are closed. And then you ask them to copy this. Now, this important thing about this is the quadrilateral in the middle. Doesn't matter what else they've done, this is what we want to see. Okay? This quadrilateral in the middle. Okay. Maximum score 30 points. Anything that is less than that, 24, mild dementia, moderate dementia 11 to 19, and severe dementia 0 to 10. I've seen like 5 in my time, which is very severe. Okay, functional activities, you really ask them how good they are doing routine things. You see some things here like writing checks and paying bills. Depends on the person, you know, suppose that they're not in a position to be writing any checks. You don't count that. Preparing meals, heating water, making coffee, turning off the stove, remembering appointments, birthdays, and so forth, and traveling out of the neighborhood, driving and arranging to take buses and so on. This is now looking at the questionnaire in a little bit more detail. The thing is, you want to, let me go back to this for a moment. You notice at the top, if you are dependent, that's a maximum score of 3. If you require assistance, 2. If you have difficulty but you can do it yourself, 1. Normal is 0. Never did the activity but could do it now, that's a 0 because that's approximating normal. Never did the activity and would have difficulty is 1. Okay. So once you have discovered what their level of functional activity is, then you score it and you deal with it as required. And one of the questions that may be a bother to you all is when you refer a person. Yes, when you refer a person to this thing, to the psychiatrist or the psychologist. I'm going to mention the geriatric depression scale, mainly to remind us all that pseudo dementia is a condition which occurs because the person actually has a depression, whether or not it's due to actually major depression or whether it's related to use of drugs, side effects of drugs, neoplasms and so on. We're not sure about that, okay? But it is important to treat the depressive symptoms first and then maybe after 6 weeks we check them to see if they're still having those symptoms, whether they're improved. If they're improved, then you know it was depression. And of course, any medications that perhaps could cause it, would be checking on that to see whether there is a link. Now this one I'm putting, and I'm not going to say much about it. It is theorized that the sense of smell goes pretty early in Alzheimer's disease, and so if you do the smell test, you will be able to spot this thing. Journal of Neurological Science, October 2013. Okay, we're going to look at the treatment. We know about the treatments, Exelon, galantamine, donepezil, which are all acetylcholinesterase inhibitors. The N-methyl-D-aspartate antagonist is the one which works against the glutamate. And the name of that drug is called memantine or Namenda. Okay? And I know that the other 3 are available. I think NMDA is now becoming available here in Jamaica, but for a long time it was not available. And it is used either singly or along with donepezil in treating the more severe dementia. Now I'm going to quickly run through, and I hope I have 3 minutes extra to just do this. Prevention. What is good for the heart is good for the brain. So you have to follow these guidelines. And I put what can you change your genes. But I think more lifestyle is the thing that we need to look at. The genetic things are not so much important, especially in our climate where we have so much diabetes and hypertension. Okay. Now, there was a study done looking at successful aging, and there are books, many books I can put two here, to do with the end of Alzheimer's and prevention. Professor Gary Small has a center in UCLA called longevity, and he advocates very much exercise, any kind of exercise. He talks about Tai Chi, he talks about yoga, he talks about weight training and so on, but even walking and swimming, if you do that in a sustained manner, it's helpful. And he talks about the fact that our brains will increase in size and function when we do these exercises, and it can last up to 5 years. But not just physical activity, mental activity too. He talks about mental snapshots, and you've done this yourself. You look at somebody, and okay, suppose you look at me, and I usually have my hair like this. You want to remember me, remember my name, say, the lady with the dreadlocks and the and slim. All right, so you remember something, and the next time you see me, it clicks. Okay? So he says this is a good thing, as well as doing crosswords and doing Sudoku and all of these other things. And he highlights very much stress management and the diet. Sleep, he says, is very important in this regard. Now, what can you take in the diet? You know, turmeric, right? That has in the curcumin, and he says this is very good. He's proposed some high potency curcumin, which he says is approved by the Food and Drug Administration. And resveratrol, which is from wine, says a little bit of wine, red wine, is good for you. But of course, you don't have to drink wine. But exercise, and then the various diets, okay, and sleep and socialization. Now here is where you can encourage your patients to really get involved with other people. It is important, not just to call them on the phone, but to physically interact with them. This is very important. It also prevents them from getting depressed and feeling as if they're abandoned by their own people. So, the other thing that Professor Small was saying is that if you're right-handed, use your left hand to do some of the things. That's going to help to stimulate your brain. All right, now, this is now quite relatively recent. They're trying to do stuff with tau and with, tau and with amyloid, the two culprits in the Alzheimer's. And they're talking about immunization, passive immunization, as opposed to active. Sometime back, they had started a study looking at using some chemicals on the brain. But what happened, they had to stop the study because there was an increase in the inflammatory response. And inflammation is the enemy of proper brain functioning. Okay? So that is not on the cards anymore. All right, now this is the name of a drug, Samaritan, which is supposed to work on the synapse. Remember that the synapse is where you have the transmission and where you're supposed to have the more acetylcholine going across. But this one now is supposed to help to keep that level up in a good way. This is another drug called PR1002, and it's breaking down the beta amyloid protein, okay, where you saw it on the video, part where it is actually the beta secretase is cutting it off at the wrong point, and the beta secretase and the gamma secretase together will cause the thing to clump up, okay? Then they talk about diagnostic processes. We talk about blood tests. And this is Gervert and the neighbors who are doing this work. And then there's on the same slide. Anyway, we want to urge you in closing to look at your patients with a compassionate eye. Do the various testings. Also do what you can to interact with them so that they have this feeling of empathy. It has been recognized that if you do have this condition, that you should not hide it but declare it, because in that way, people will be able to interact with you in a more reasonable way. I talk particularly about caregivers, people who we bring in from outside. The person is in an advanced state of dementia. They're wetting themselves and they're soiling themselves, and they're not doing it to spite you. They're doing it because that is how the disease has progressed. So they must have that compassion. And people who are looking after Alzheimer's patients must take care of themselves too. Some of the steps that we are talking about with regard to prevention, those people must use those things in order to keep themselves well. I have seen stories of people who are at the stage of suicide. They would kill themselves and kill the person with the disease because they can't take it anymore. It's an expensive proposition. It's a time-consuming endeavor. You have to leave your work in order to sort out. So it is important to recognize and be able to deal with persons in a compassionate manner. Now my time is up. I did have another video. I don't know if you'll give me permission to show it. It's 3 minutes.
All right, go ahead.
Thank you. It just distills the Alzheimer's message, yes.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
Thank you very much, Dr. Barnaby. A lot of research went into that, as Aldyth will share with me. New things we have learned, difference between the hippocampal versus frontotemporal lesions. The MCI, I'm never heard of a functional MCI or MCI functional MRI. The difference between MCI and dementia, if there's any difference, or if it's a pre-diagnosis. Tau in CSF, tau protein stabilized microtubules, I learned that, and more detail about the clot drawing test, and if there's immunotherapy or dementia at all. More research is being done as we recognize the more discoveries with the chromosomes, different chromosomes, and I hope we expand treatment measures when prevention fails, and also rehabilitation. We're going to invite our sponsor, one of our sponsors, Medimpex, to come up and do a 5-minute presentation. Ladies and gentlemen, please welcome one of our sponsors. They've been there all while for us. They look different in their uniform this morning. Please put your hands together and welcome Medimpex. Introduce yourself. And talk. Okay. And then share.
Good morning, everyone. My name is Ashley Wong. I'm a medical rep with Medimpex, and with me today is my colleague, Simiko Alexander. She's also a medical rep. So, in keeping with today's theme of dementia, I will be talking about Physiotherapy. First things first, I wanted to let everyone know that Medimpex has relocated, so we are no longer on Ripon Road. We are at 21 Balmoral Avenue. That's where you can find us. Okay, so as I mentioned, we're going to be talking about Physiotherapy, which is our brand of donepezil, and we carry both the 5 and the 10 milligram strength. Physiotherapy is used for the treatment of mild to moderately severe Alzheimer's disease, and of course, Alzheimer's is a type of dementia, so it's actually a progressive dementia. And it's also good to know that I said severe Alzheimer's disease because it is the only cholinesterase inhibitor approved by the FDA for severe Alzheimer's disease. Okay, so how does Palixid work? As I mentioned, it is a cholinesterase inhibitor. And of course, for your Alzheimer's patients, there's a relative lack in acetylcholine, which is a brain neurotransmitter. This brain neurotransmitter is very important in helping to form new memories. And so what Palixid will do is that it will stop the breakdown of the acetylcholine. And so there's more available in the brain, which means that your patients are able to form new memories. Palixid's product profile: the peak plasma levels are 3 to 4 hours after oral administration. The half-life is 70 hours. The steady state is achieved within 3 weeks of initial therapy. It's 100% bioavailable. The protein binding is 95%, which means it's given once a day. And food does not affect absorption. It's metabolized in the liver via the cytochrome P450 system. The dosing for Palixid: the initial dose is 5 milligrams once per day in the evening before retiring for at least 1 month. Now, after a 1 month assessment, you can increase the dose to 10 milligrams. And 10 milligrams is actually the maximum daily dose. For your patients who may have renal and hepatic impairment, the same dosing is required because clearance of the drug is not affected. Of course, Palixid is not recommended in children. Contraindications: this one is obvious: patients with known hypersensitivity to donepezil, also periprudine derivatives, as well as pregnancy and lactation. Okay, so if you're going to put your patients on Palixid, you have to take some things into consideration. In terms of anesthesia, it may exert muscle relaxation. For patients who have cardiovascular conditions, it can cause severe bradycardia. For patients who have GI conditions, it can potentiate peptic ulcers. For the genitourinary conditions, it can cause bladder outflow obstruction. For patients with neurological conditions, it can cause seizures. And for patients with asthma and COPD, you have to be very, very cautious. So, drug interactions. You have to consider ketoconazole as well as quinidine and inhibitors of the CP3A4, right? So that's like your itraconazole, for example. Enzyme inducers, and you also have to consider synergistic activity when given with neuromuscular blocking agents. Side effects of Palixid: these are the most common ones: diarrhea, muscle cramps, fatigue, nausea, vomiting, insomnia. As I mentioned, Palixid comes in 2 strengths, the 5 milligram as well as the 10 milligram. Okay, my colleague Simika is going to take over from here. I'll also mention the cost. So Palixid is very affordable, especially when you take into consideration the price of the brand. So our 5 milligrams from Medimpex, the patient would be about $6,000. Of course, there's a markup at the pharmacy. The 10 milligrams is about $7,000. Again, this is from Medimpex. Please keep in mind the pharmacy will put maybe a 40 to 50% markup on that. So I'll hand over to Simika.
Hello, good morning, everybody.
Good morning.
So I know that we're all warming up to the new normal. So I just want to say thank you for all those who braved the storm and came out this morning. So I'll be presenting on Cavinton. Ashley presented on Palixid before, so most of us should know Cavinton. And Cavinton is actually vinpocetine in a 10 milligram strength. And as you can see, the box comes with 30 tablets. All right, so Cavinton is actually indicated in acute and chronic cerebral circulatory insufficiencies. It can be utilized in patients that have experienced progressive and completed strokes, transient ischemic attacks, cerebral arteriosclerosis, memory disorders, and it's also indicated in vascular dementia. In addition to Cavington, we have had a vitamin line newly distributed at Medimpex, and this is our Prime Health line. If you come outside and visit the booth, you'll see a few of them. And some that I want to highlight today are our omega-369, our glucosamine and chondroitin, as well as our vitamins for adults 50 and over, complete adults 50 and over. So these are some of the vitamins. This is how they look. You can take a look at them on the outside later today. And then this is just a general price list of the vitamins that we have. So these are the prices from us. Obviously, there'll be plus tax because they're over-the-counter items. And as Ashley had mentioned before, once it is that they do get in the pharmacies, there will be a markup on them. Okay. And as I mentioned before, just a reminder, we're now located at 21 Balmoral Avenue. That's the Heart Institute Hospital, if you can bring that in your recollection. Right. And then the Heart Institute. Any other? That's it from us. Thank you for your attention. Has any questions? Oh, we have 2 prizes to give away. We have 2 prizes to give away. So I wanted to see if anybody was paying attention. Sorry for those who are on Zoom. This is not open to you, unfortunately. So for those who are here, we have 2 prizes to give away. So I just wanted to see if anybody was paying attention. So who can tell me the 2 strengths of Palixid that we have? So everybody's answering so quickly. So we have to go give the 5 milligrams and 10 milligrams. Okay. And it's not okay. So you should give me extra extra answer.
Dosing as well, though.
Tell me what the dosing is. You can tell me what the dosing is?
Is this muted right now?
Awesome. So you deserve the prize. Yeah, she deserves the prize, right? All right. Yeah, she can get, actually gonna go for them. All right, the next question, since everybody wanted to answer so quickly, please raise your hand first. The next question, who can tell me 2 of the indications for Cavington? Yes? It's okay, you win your prize already.
Royal, go on. No,
Go on, that's a Royal. Mm-hmm. Right. Okay. You can tell me what the ingredient is, what the molecule is. Remember? It's alright. So not very pressure, but it's vinpocetine. Vinpocetine 10 milligrams. All right. So thank you for participating. Everybody will get your prizes for you.
Thank you very much. Thank you very much, Medimpex, for being there always for us. Our second presenter, we have an Aldyth. Our second presenter, I don't know if I'm pronouncing the name properly, Ishtar Govia or Govia. Govia. Okay, Dr. Govia is a research psychologist employed as a lecturer in epidemiology at the UWI Mona, where she's the institute's leader and integrated prevention management for mental health. She is dedicated to gender and equity sensitive research on holistic and integrated prevention and management of non-communicable diseases. Dr. Govia's current projects include the Jamaica arm of a multi-country dementia care improvement study called STRIDE, as you heard in my introduction of Dr. Barnaby. STRIDE means strengthening responses to dementia in developing countries. Now, this project is coordinated by the London School of Economics, with research being conducted in 7 developing countries, I suppose including Jamaica, to understand and inform national and individual practice and policy for people living with dementia and their caregivers and their carers. Dr. Govia is also passionate about her consulting practice, helping persons living with dementia and their care network with care management and coordination. For more information, you can get her online. Ladies and gentlemen, help me I'm introducing and asking Dr. Govia to talk on approach to dementia prevention and management, which will include lifestyle habits, team approach, use of NI disability assessment form, and defining mental competency while making a will and also a legal guardian. Please help me welcome Dr. Govia. Thank you. Dr. Govia, you're online. Thank you.
Thank you. Can everyone hear me well?
Yes.
Great. All right. So I would like to thank the Caribbean College of Family Physicians for having me to be part of this conference. And I would really like to commend the CCFP for having this conference in the first place, because dementia, as Dr. Barnaby was mentioning, is a
Sorry, on your tail, please. Yeah, 1 second, she's muted.
Can you hear me?
Yes, we can hear you now.
Okay, great. All right. So I'd really like to commend the Caribbean College of Family Physicians for having the conference, because dementia is a severe issue that's facing all countries around the world. We know, as Dr. Barnaby was reminding us, that every 3 seconds, someone in the world develops dementia. That doesn't mean that every 3 seconds someone is diagnosed with dementia, because as Dr. Barnaby showed, diagnosis is a very complex issue and not many persons are actually equipped to diagnose dementia. Dementia in Jamaica, we know we have a prevalence, a pooled prevalence of approximately 9% of the population of persons who are 60 and older, and quite likely this number is going to rise exponentially over the next decades, as we have, again, as Dr. Barnaby showed, an aging demographic. To remind what happens with dementia, and in particular, this image shows you what happens with Alzheimer's disease, we know that dementia is really changes to the structure and the functioning of the brain. We know our brain is responsible, it's the central engine for our bodies, and the changes that happen with dementia-related processes are those that interfere with the brain's cells' abilities to communicate with one another. And so this, again, similar to the video that Dr. Barnaby showed at the end, you see that that change and that interference then obstructs our ability to think, our behaviors, and our feelings as well. In thinking about prevention, in thinking about management, it's important to think about who is involved in care. And we know, as this survey from Alzheimer's Disease International showed last year, that over 50% of healthcare practitioners agree that their own colleagues ignore persons living with dementia. And that 33% of people believe that if they had dementia, they would not be listened to by health professionals. And again, this is why it's so commendable that this organization is having this session. There are many different pathways to dementia. Dementia is an umbrella term, and it's different types of disease processes that lead to what manifests as dementia. There are over 100 different causes of dementia. Alzheimer's disease is the most common, but there are other pathways. There's alcohol-related brain damage. There is also an increased likelihood of persons who have learning disabilities developing dementia. We know that the most frequently occurring type of dementia is Alzheimer's disease, very closely followed by vascular dementia, and then Lewy body and frontotemporal dementia, which is a type of early onset dementia. There are differences, distinctions between different types of dementia, and it's important that as physicians making these diagnoses or suspecting that there may be a dementia-related process happening, that you understand the distinctions between different types of dementia, and not just that you understand it, but that you're able to communicate that with the persons that you care for. So we know that Alzheimer's disease, for example, is not curable thus far. It's not reversible, and the symptoms come on gradually. There is a linear type of progression in terms of the deterioration of the person's abilities to reason, to speak, and eventually to move, and finally to eat and breathe. And that this type of dementia is more apt to develop as persons age. And again, as Dr. Barnaby showed really beautifully with a lot of visuals, this is caused by plaques and tangles. We do not understand the mechanisms that are driving completely the development of the plaques and the tangles. And so it's important to understand that prevention, in terms of the individual level of prevention, cannot be definitively prescribed at this point in time. Vascular dementia, we know, is a type of dementia where the symptoms come on very quickly, and memory loss is actually one of the last symptoms to occur. So with Alzheimer's disease, recent memory, short-term memory is one of the things that people notice first. But with vascular dementia, there are other types of changes happening. And so these changes that relate to damaged blood vessels in the brain and shrinkage of blood vessels have impacts in terms of people's abilities to perform physical activities, walking, talking, etc. Even visual perception is sometimes affected. And then dementia with Lewy bodies, it's very common to resemble Parkinson's disease. And there's muscle stiffness, there's hallucinations, etc. And this type of dementia affects persons' perceptions and their behaviors as well. What happens in dementia? In the early stages, Dr. Barnaby again referenced early, middle, and late stages. In the early stage, we have short-term memory loss, particularly with Alzheimer's disease. You see subtle types of personality changes. There is confusion and disorientation. The person may misplace things. So for example, they may put their shoes in the fridge, or they may take their glasses and put their glasses in a pot that they were watering with a plant. So there's misplacement of things, putting things in peculiar types of locations, putting things, for example, we see this very frequently with households where a woman is responsible for most of the cooking. The things from the kitchen find their way into the bedroom, into the drawers. And so those types of strange behaviors are things that people speak about very frequently. Losing track of your thoughts very often, having to pause. And it's important to recognize that these early stage types of indications are often very, very easy to mask. And persons really look to other people in their environment to see how to behave. So there's a lot of mirroring happening when the person is at this early stage of dementia. In addition to feeling petrified, if you can imagine this happening to yourself, and your whole sense of how you make sense of the world is changing, and you know this, you're trying to figure out how to navigate the world as you know it. So it's very easy for the person who's at this early stage, and this early stage can last a long while, to mask especially by mirroring, particularly with people who are closest to them, people who are in their households. The middle stage, and this is what we tend to see a lot in Jamaica. People tend to realize that something is wrong. People in the person's care network, in the person's immediate household environment, tend to realize that something is wrong when they see that their loved one has a need for assistance with daily tasks. When they see that there are peculiar gaps and lapses in memory, where there's a repetition of conversations that have happened already. And it's as though those conversations didn't happen at all. Even very serious decisions that are made, the person may have absolutely no recollection of them in one moment, but then they are able to recall it maybe 2 hours later or the next day. And so it's really important to pay attention to these types of things and to ask information of your patient, of this person who's coming to see you, so that you normalize the need to find out this type of information. Because otherwise it may just seem like an embarrassing thing to happen to the person, and they'd be very less willing to disclose. The person increasingly may also display anxious or agitated types of behavior. They may even seem delusional because they may be having hallucinations, whether it's auditory or visual hallucinations, and they engage in what we refer to as obsessive behaviors. So they stick to what they know. So you see a lot of unpacking clothes, packing clothes, a lot of folding, a lot of taking papers and ripping them up and stacking them, and then ripping up more papers, going into drawers, digging up the things, stacking those things, putting those things back. So there's a lot of obsessive behavior. And why does that happen? Because it's very soothing for the person who is living with dementia. And then finally, there is a loss of clear speech. So over time, the person's speech patterns evolve so that there are words that are entering into sentences that don't seem appropriate. There is a lot more of disinhibited behavior. So for example, you may go into a store with your loved one and you see the person picking up candies and just putting them in their mouth. And that happens because the part of the brain that's responsible for really controlled types of behaviors and understanding what's appropriate and not appropriate, that part of the brain is affected really severely. Whereas in the middle stage, you may see the person using bad words all of a sudden, saying things that you think are very uncharacteristic of the person to speak about, their sex life, or just bad talking people in general. Those types of verbal communications are reduced even more in the late stage. So in addition to inserting words that don't seem appropriate in terms of a sentence, sentences themselves become even less frequently occurring. There's also a greater tendency to have incontinence, a loss of bowel and bladder control, and then difficulty with mobility, and finally, a difficulty with swallowing. So in the face of this, we have a bombardment because everybody is petrified of dementia. If I ask those of you in the room or those of you online, raise your hand or indicate if you know somebody who's living with dementia. The vast majority of you probably know somebody who's living with dementia. You've probably treated somebody who's living with dementia. And there is an urgency in these cases to talk about prevention. How can we prevent this? How can we prevent this? But the truth is, often these disease processes occur 15 to 20 years before you even see the signs of the early stages. And this is why it's important to talk about risk reduction, because we don't understand the mechanism. The science has not advanced to the stage in which we can understand the difference, as Dr. Barnaby was suggesting, between mild cognitive impairment and early onset dementia, and figuring out what point to intervene. And so you see a lot of snake oil types of approaches to thinking about treating dementia and preventing dementia. But the truth is, these things are very individualized because each person has an individualized disease process or pathway and has their own types of risk factors. Where does STRIDE come in? So instead of talking about prevention at an individual level, we're also thinking about prevention in terms of upstream determinants of health and thinking about ways in which we can improve our health and social care services and health and social care systems. And that's the big picture in terms of prevention that we're focused on in the STRIDE project. STRIDE standing for Strengthening Responses to Dementia in Developing Countries. And Jamaica has the honor of being the only Caribbean country that is included in this project. As you heard from the introduction of Dr. Barnaby, we have a national advisory group which was formed after our initial meeting in October 2018 of over 50 different stakeholders. These are persons who are living with dementia, carers, persons from all of these entities and much more entities, many more entities, who articulated what the priorities are for us in Jamaica. And so it's really important to understand that the program of work in terms of prevention and management that I'm going to be speaking about today is very much intricately driven by our local concerns. Specifically, for example, our National Advisory Group found that what we need to have is a much more accessible pool of information in terms of services for persons living with dementia. I'll speak to that a little later on. We need more research, we need more awareness raising, and we're working very hard with the National Health Fund for the subsidization of medications, because even though, as we saw in our sponsor's presentation just now, these medications may seem affordable, remember that many of the persons who are diagnosed with dementia in Jamaica have multiple comorbidities. And so it's not just the dementia medication that they have to pay for, it's the medication for their multiple other conditions. So how can we think at an individual level now in terms of risk reduction? One of the very important things that you as physicians can really have a major influence with is understanding who you're treating, who your client is, who your patient is, particularly those who are parts of the sandwich generation. Probably most of you yourselves are also members of the sandwich generation, meaning that you're not only caring for your children, but you're caring for persons who are older than you. And in that type of context, your own health and wellness matters a lot. It's important to keep in mind that your brain health is whole person health. And that's where these risk factors come in. There are modifiable risk factors. There is a range of evidence that exists. There is strong evidence and there is unclear evidence. What we know, for example, is that traumatic brain injury severely increases the risk of dementia progression and having dementia. In Jamaica, we know, for example, that we have a high prevalence of motor vehicle accidents. We also know that we have a high prevalence of domestic violence. Those are two types of situations that are very strongly associated with brain injury, whether that brain injury is immediately apparent or it manifests later on. And because the vast majority of the population do not get brain scans, this is quite likely that these brain injury processes, like you see with the footballers who have multiple concussions, these brain injury processes are having effects even though they are not formally diagnosed. We spoke already about, Dr. Barnaby really spoke a lot about these modifiable risk factors in terms of lifestyle risk factors. There is extensive research that suggests that obesity, particularly midlife obesity and midlife hypertension and current smoking and diabetes increase the risk for dementia. And there are a couple of things that reduce the risk, particularly years of formal education and physical activity. We don't understand the mechanisms, again, by which these things increase risk and the things that decrease risk. But what we do know is that this is what extensive research has found to be risk factors and protective factors. In over recent years, what we saw from the Lancet Commission is that at least 35% of dementia risk may be within our control as individuals. And this is why it's important to think of this yourselves as physicians. We're seeing a high prevalence of poor lifestyle behaviors among health professionals, and clearly it's because of the stressful nature of work, etc. But it's important to understand that as you get older, those modifiable risk factors take on an even more important role in terms of the appearance, the manifestation of diseases. Hearing loss is one of the risk factors that persons don't normally talk about, but it's very connected to if you're able to manage hearing loss, Just like if you're able to manage visual perception, you're in a much better place in terms of navigating other weaknesses within your system. So how did we learn about local needs and the most helpful approaches? The STRIDE project has really taken a very hands-on approach to understanding and hearing from persons locally about what their needs are. We have a very, very active and engaged national advisory group. We've been in multiple places of worship. We've been on the television. We've been on the radio. And it's through these regular processes of engagement that we get feedback from persons. Here's what they're doing. Here are the types of responses they're getting from their health providers. Here are the types of needs that they have as persons who are really trying to manage it either for themselves or as carers. And what that suggests to us is that we need multi-pronged care management. So Dr. Barnaby spoke a lot about diagnostics. She spoke a lot about medical professionals, but I also want to make the case for allied professionals as well. So speech therapists, physiotherapists. There are other persons who are involved, particularly, for example, with vascular dementia. It's very important to get a speech therapist involved as early as possible. We heard about pharmacological interventions, but these changed behaviors, and we don't talk about aggressive behavior, we don't talk about problematic behavior, because again, we don't know what the person is going through. So where you see changed behaviors, non-pharmacological approaches are really important in terms of understanding changed behaviors. Spatial adaptations, I'll speak about that a little bit more. Formal care and informal care. So formal care as in by a nurse or by a certified care assistant. Informal care, like the care that family members provide, or even the care that church brothers or sisters can provide. So often what we've heard from persons on the ground is that they're given a suspected diagnosis or a formal diagnosis, but then they're sent out of the doctor's office without any clue about what to do next. Can you imagine if this was yourself and you've just received a diagnosis, or you're told that you think your doctor tells you that there may be this disease process happening, dementia, you quite likely are experiencing signs of dementia. That could be extremely anxiety provoking. So it's really important that as physicians who are the front line, you are the first persons that often your patients are seeing when they have concerns. It's very important that you really buffer and build up and augment your the interpersonal aspects of it. So the first thing to do is to manage emotions and family dynamics. You have to encourage the individual to accept their feelings of sadness and fear, and quite likely, because what we hear from the persons that we speak with and the persons who we do consultations with is that there's a rush immediately. Let me give you medication for anxiety. Let me give you medication for depression. But to not say to them, this is a very appropriate type of response. You know, this is a very appropriate response to some massive news that you've just got, or to some massive changes that you're experiencing. So encourage them to allow themselves space and time. And it's also very important to sensitize them to anticipate resistance or denial from their loved ones. Because even if the person who you are dealing with, even if your patient may be, shocked, may be really trying to process this, at least they might want to start that process. But if they are encountering resistance or denial from family members, then that makes the process even more tricky to navigate. So it's important from the beginning to get as clear a sense of the dynamic, the family dynamic as possible. So along those lines, encourage them to host, for example, a dementia information session. And you can invite a dementia expert or a gerontologist to come and speak with them so that they can have a sense of what to expect on the journey and the progression. Because the earlier you have the intervention, the better it is for the person being able to have a longer period of time for independent living. So it's important to plan for this progression. And people tend to resist this at first, but it's important to just very gently, sensitively communicate the need to plan for the progression. This includes doing things like getting a living will, which is advanced medical directives. You need to have that drawn up. The person needs to have that drawn up. So we need to normalize these types of conversations in our practices. There are different types of power of attorney that exist. There's a standard power of attorney, and that's not valid for somebody who has already, in your practice, if you see this person as a patient, received some notification from you that there may be a suspicion of a dementia process, or you may have already formally diagnosed them with Alzheimer's disease. That power of attorney is null and void. So what you need instead is a durable power of attorney, which lasts regardless of how that person's capacity changes. Or you need what's referred to as a springing power of attorney. And a springing power of attorney is one that literally springs into effect. It's activated when you see the change in somebody's health condition. It's important that you encourage them, and Jamaicans hate to do this, Caribbean people in general, we hate to do this, to think about our wills. It's very important to encourage them to develop and to update their will. As doctors, it's important that you are aware of the NIS disability plans. When you write your report, when you give a sense of a diagnosis, that is necessary. Your client, your patient needs to be able to take in that documentation to the NIS office so that they can have the benefits. And then having conversations too with workplaces is important. Again, the earlier you're able to start these conversations, theoretically, the better, because then even the workplaces can think about ways to adapt and adjust. Admittedly, there is still enormous stigma around this, and people believe that dementia, receiving a diagnosis of dementia, is an immediate death sentence. As you saw from those excerpts that Dr. Barnaby showed, there are cases in which the person who has received the diagnosis of dementia is not even talked to, even if they may be in the early stages or the early middle stages. It's important that we remember the dignity of persons and we treat them as persons throughout our care. Banking and finances, utilities. This is a huge one. Persons who it's only their name on accounts, particularly as their functioning starts to deteriorate, that becomes increasingly problematic, and they're much more prone to being taken advantage of, even by unscrupulous people within banks and within utility institutions. So it's really important that as soon as you believe something is happening as a physician, that you start to think through, after you've gathered information, how to bring up this type of conversation, or you refer to a dementia care consultant to figure out how you can help your patient to think through these types of issues, because it's really difficult. I know many of you have had experience with this, to transfer names for utilities and for accounts after certain types of health conditions have happened. And then it's important as well that they consider who they want to be responsible for their property and assets. So some of this can be integrated into the will, but even if there is a resistance to writing a will, having some documentation that is signed and is witnessed is important in terms of understanding responsibility for property and assets. One important element that persons need to consider are decisions about relocation. And it's important to think about relocation because the objective, all persons with dementia can live well. They can live well. So what you're trying to do in introducing considerations about relocation is thinking through this question of, how can this person live as independently as possible for as long as possible? So you have to think in terms of timing and the stage of the progression of the type of dementia that they have. Particularly in cases of Alzheimer's disease, where the short-term memory goes first. And so if you think of it as a stack of books or papers, and your recent memories are the ones that are at the top, and your longer-term memories are the ones that are at the bottom. If a breeze comes, which is what Alzheimer's disease does, it's like it blows the papers from the top off. That's your recent memory, your short-term memory. But what you have are the medium-term memories, the longer-term memories. So if you have a case, for example, of a family, a person who's been living in a house for the vast majority of their adult life, and the family members see that the dementia processes have started, they may make very quick decisions. We need to move this person, but that's not considering the person's needs, and it's not considering the disease process either, because you want the person to stay in an environment that feels the most stable to them. But if you do that too late, it can also jeopardize that individual's safety and health, because again, we've heard some examples of the types of things that happen. There's inappropriate use of things. Their short-term memory leaving. They may be walking into the kitchen to prepare a sandwich and may have used a knife to cut bread, and then start to walk around with the knife in their hand, because their visual perception, their depth perception is changing too. They can easily trip and fall on that knife, on that sharp object. So it's really important to think in terms of safety. What is the risk of their harm to themselves? What's their reaction time like? What's their judgment like? And things like driving, again, that becomes an important consideration. Health, medication. We know that on the best of days, adherence is really poor for many people. So we have to think, particularly if we are prescribing medication to help with the management of the early stages of the disease processes, that medication is being taken at the dosage and at the frequency, so that you're able to then, in your follow-up appointment with the patient, you're able to gauge, is this working? But you can't tell if it's working if you are relying on this person who is losing short-term memory, as in the case of Alzheimer's disease, to remember to take that medication. So all of the home and environmental circumstances need to be considered. Nutrition as well needs to be considered. As persons get older, even those who are in good health, the regularity with eating tends to drop off. And so it's important to think in terms of food storage and preparation. For example, are they eating moldy food? Mold has also been implicated in some of the disease processes that we see in some types of dementia. So it's important to make sure that the environment, the built environment, the home environment, is as safe as possible in terms of nutrition. And then another key consideration is finances. Is that person able to handle their day-to-day financial transactions on their own? Or, as we heard from a member of our national advisory group, when she would go to who is a person who's living with dementia, and her sister, when they would go to the market, people would prey on her because they knew that she was not remembering that she had just been to that stall. And so they would they would speak to her as though she hadn't paid, but you haven't paid me yet. And then she would panic and then think that she'd need to pay again. So it's really important to think about things like financial management. Management of living space is really, really important. One of the first things that we recommend is that if the person can live on the ground floor, particularly if it's a multi-story space, that you ensure that the person is set up on the ground floor. You have to clear clutter, because what happens to the person who is having the dementia process occurring is that stimuli feel overwhelming. You could have the radio on, there's a conversation happening, there's a door closing, there's a car coming, and all of that just feels like too much noise to the person with dementia. So similarly, if the space is cluttered and their depth perception is changing, their visual perception is changing, plus they're feeling this bombardment of stimuli, even in some cases as well, having hallucinations, it can feel really overwhelming. You want to simplify the space as much as possible. You need to think about safety switches for ovens and stoves, and safe storage for sharp and tiny objects. Lighting is very important, and grab bars, installing those. Visual reminders. This tends to be very variant person to person, because some people may feel like you're treating me like a child to have all of these written reminders all over the place. But other people may find those to be really helpful, or the electronic reminders as in the phone systems or sending a text. So, and then some families really do need to think, particularly those in the sandwich generation, they really do need to think about assisted living facilities. And this is one of the things that we're working on in the STRIDE project, is again pulling together this directory of resources. So as physicians, as allied health professionals, allied social care professionals, it's important that we practice person-centered care. This is care that is personalized, coordinated, and enabling. So we know that physicians can sometimes work in silos. So the cardiologist is doing one thing, the psychiatrist is doing something else, the physical therapist is giving messages about something else. The rheumatologist is giving some other recommendations. It's very important that care is coordinated and that you empower your patients and their families to get information that they need to ensure that their care is coordinated. So persons need to be able to get a report from you that they can take to their other healthcare provider so that they can see what is the current status of this person's health. Care also has to be personalized. So there is not a one-size-fits-all type of approach with dementia care. The care has to be personalized. That level of personalization is about the risk factors that this individual has, as well as the resources that this individual has. And care that is enabling. What do we mean by enable? It's care that allows this person to live as independently as possible, to have as good quality of life as possible for as long as possible. So how do you do this as physicians? How do you facilitate this as physicians? You have to customize it to the stage of dementia. And remember that one day for somebody who's living with dementia could be very different from another day for that same person living with dementia in the same stage. So it's important that you you normalize this variation, but you have to customize it to the stage of dementia. You have to customize it to the type of dementia. There are so many times that we do consultations and we say to the person, what type of dementia is it that you've been diagnosed with, or that your husband has been diagnosed with, or your mother has been diagnosed with? And they said, the doctor never told me that. So I assumed it was Alzheimer's disease. So it's really important that we get clear in terms of our communication to our patients, to our clients, because that care, that level, remember the medication for vascular dementia is different from the medication for Alzheimer's disease. Yes, there are mixed dementias. There are persons who have Alzheimer's disease and also have vascular dementia, but we also need to be clear as we're communicating with our clients, with our patients, about why exactly we're prescribing this particular thing. And then you have to remember, again, the individualized level of this, the variance person to person. You have to care for that specific person who you're dealing with. Some questions that can help you as you help them. You help your patient and you help their families. What was this person's daily routines and schedules like? So, for example, if they got up very early in the morning and they got ready to go to work as a teacher, you may have to think about an environment where there is the make-believe. You go along with their make-believe that they're getting dressed to go to work to teach at their school. And you just ensure that the setup at home is conducive to that the care assistant that you have is aware that this was this person's routines and this was this person's schedule beforehand. Think about the soundtrack of this individual's life. Music has been shown to be extremely therapeutic, particularly for persons who are at the middle and later stages, because what it does is it accesses a part of the brain that is beyond words. It may sound ironic because many songs are actually have lyrics to them, but it recalls the emotion. And it's important, again, to remember that emotion plays an important role for persons living with dementia, because they may not remember exactly what you said in an interaction with them. They may not remember when they had that interaction with you, but they remember how they felt in that interaction with you. And so it's important really to cultivate positive feelings in the person who is living with dementia, and to avoid the types of situations that could potentially agitate the person. So as care partners, it's important to be empathetic, to constantly educate yourself. Dementia is such a dynamic disease process, and it's also a dynamic, an area of work where there are constant advances and progressions. They may seem very subtle, but they all add to the totality. Be creative, and remember, you do not have to do this alone. You as the physician, even though you are often the first point of contact for your patient, you do not have to do this alone. It's important that you take a team-oriented approach to care, and that you enlist the help of persons. You make referrals to persons who are other experts and can help with management. And then yourself, often is not talked about, but as physicians yourself, dealing with and working with patients who have a dementia diagnosis, and Jamaica is a small society. The many Caribbean countries were very small societies. We get to know people really well, and we get attached to them. So in addition to the preparation for the final stages and for saying goodbye, and that's a whole other session that we can have in terms of how you prepare for a good dying process, a good death, and the ways in which you set that up from very early stages, having conversations and making death not such a taboo thing to talk about. But it's very important that as physicians, you yourself can acknowledge that there is an attachment to your patients, and that you yourself also have to prepare for their final stages. It's important to avoid burnout as well. Do not give in to guilt. You cannot do everything as their physician. So you often may feel guilty that you're not available all the time. You're not available when they're in an emergency situations, and there will be constantly emergency situations, particularly in the early and middle stages. And it's the middle stages that you tend to see. We in Jamaica, we tend to see a lot of patients, clients, because that's when people realize something is wrong here, something is not happening properly. And then those are where emergency situations escalate. You may have persons who they may be a threat to themselves. They may be at a window, standing up curious about what is this window, what is this thing here for, and they start to try to move it, and it's not moving, and then they get really afraid and they feel trapped, and then that escalates and something may break. They may become a danger to themselves or to other people. You will constantly have situations like that when somebody's in the middle stages. So it's important also to seek out other caregivers. It's important to consider your own health. Again, really important to emphasize, because many of you, physicians are not exempt from developing dementia. And that's really important to understand that, particularly because some of the coping strategies that we have in our area of work are not the healthiest. We rush to get the fast food because we don't have time, patient to patient. We feel so burnt out when we get home. We need a glass of rum, or we need, we end up having a half a bottle of wine. It's important to acknowledge that there are some habits, some self-soothing coping strategies that put you physicians at risk. And it's important to take action. Speaking of taking action, it's important to partner, and it's important that we all work together. And so the Stride Jamaica project, again, our focus is on improving dementia care. we are compiling an electronic directory of available services for persons living with dementia. And we would love to be able to share this link with you so that you can complete this form. It's very short, like 10 questions, and most of it check boxes. So if you can help us clarify what the landscape of care possibilities are, this information can then be funneled back to you so that you can then help with appropriate referrals as well. Another thing that we're working on, the World Health Organization, I see that Dr. Goldborn is on today's call as well, is the Global Dementia Observatory. And working with the Ministry of Health and Wellness in Jamaica, and again, this is upstream determinants, so upstream types of prevention efforts that we're talking about here. We are focused on trying to understand what information we have for dementia-related care in Jamaica. And many other Caribbean countries are also having to produce data to submit to this GDO platform. Again, we have a questionnaire which we would love to be 6 questions only, very quickly. It doesn't take you more than 5 minutes, if even that, to do. I think it's more like 2 minutes. We would love to be able to disseminate this to the CCFP, and so you can help us with identifying and completing the information for this. And then finally, I see Pam is on from Kiwani's Foundation of Jamaica. On the 12th of September, we have Kiwanis for Disability Day Jamaica. Some of you may know that September is World Alzheimer's Month, and so it's really important that we're all on board, all hands on deck in terms of sensitizations around dementia and all types of dementia. This year's theme for World Alzheimer's Month is the same as last year's theme, which is Let's Talk About Dementia. So this forum is an excellent example of that. But in September, we will be partnering, Stride Jamaica is going to be partnering with Kiwani's Foundation of Jamaica. We will have a launch on the 11th of September, again, physically distant and ensuring all protocols are in place, where we'll have a tree planting ceremony with the governor. And on Saturday the 12th, we will have a virtual symposium, similar to this as well, where we will be doing multiple workshops and symposia that would help both particularly informal carers of persons living with disabilities and particularly persons living with dementia. So as we wrap up today, I just want to encourage you to reach out to us, look us up. I offer free dementia care management consultations. I do it via Zoom, via telephone, particularly now because persons living with dementia and their carers are within the vulnerable population. I just do virtual modalities, but we're doing a lot of different engagement work. So I wanted to just share that information with you. If you know of anyone who can benefit from help in terms of thinking about what is going on and how do I navigate what could possibly be a dementia pathway here, we are available and we're very happy to help. So thank you.
Thank you very much, Dr. Govia. That was very extensive. A lot of research went into that. We really appreciate your presentation. Can you hear me? You can't hear me at all? You can't hear me?
Yes, I can hear you.
You can hear me?
Yes, yes.
Oh, okay. All right. We're very thankful. I gathered a few things, things which should be well known to me about the team approach in such patients. And then what also dawned on me was the spatial adaptation, which you mentioned about assisted living, management of living spaces, and then sometimes we want to take the independence from our loved ones, but we have to be careful about the timing, the safety, you mentioned, the health, the nutrition, finances, especially driving. My 91-year-old father thinks he's not having dementia. He wants to drive at 91. management of emotions and family dynamics, power of attorney. I didn't know there was a difference between the usual ones and durable versus the springing one. Now I know. And awareness of the NIS disability plan. For benefits, thank you very much for your contact number, 405-8629. So those of us who are getting there, and I think when I leave my phone in the fridge in the car, key in the microwave, you know that I'm getting there at 60. So I will call you shortly for a 35-minute interaction. Any questions from those here and from those on webinar? Any questions to the two presenters? Dr. Barnaby is still here with us, and Dr. Govia is online. Yes, Aldyth, you can come and ask your question. Our immediate past president, she can stay there. Okay.
Dr. Govia, thank you so much for your presentation. I can see that you did a lot of research and extensive preparation for all particular setting as physicians. You mentioned important things, and we will contact and collaborate so that we can actually be also on the platform so that others know who we are as well. Thank you so much for that. You shared so much practical information, and I just want to let you know how much I appreciate it. Thank you so much.
Chair? Yes, I was.
Question coming up?
I have a question.
Yes, Dr. Williams Green, you can go ahead.
Yeah. The question is to Dr. Barnaby. She mentioned depression as a pseudo form, a pseudo dementia. But for the persons who are receiving the diagnosis of dementia, especially in the early or the middle stages, is there a role to treat with antidepressants? That is my question.
Yeah. Dr. Barnaby will answer you shortly.
Yes.
Let me just say that initially, with the first presentation of the individual, you have to always rule out. Depression. But start with
Not hearing.
Are you hearing now?
Little better, yes.
Okay. Yeah, so in the initial stages of any presentation of a person with suspected dementia, it is important to rule out the depression. But as the disease progresses, the individual can develop depressive symptoms, just like how they can develop the psychotic symptoms, you see. And in that case, then you treat as required, you see, because in this condition, not just in dementia generally, not focusing on Alzheimer's, we have to deal with all of the behavioral and social effects that occur. I remember that some of these people have to do all the diagnosis, or maybe triple and quadruple diagnosis that you have to deal with, and all of these other things can also promote depressive symptoms. So there is a role. Okay, thanks.
Thank you.
Before I go to any question, my special thanks to both Dr. Barnaby and Dr. Lorraine. I must let you know on the questions that we were approached 2 weeks ago, or they prepared so well as if they were approached since 3 months or so. And with this, I publicly tell them thank you, because I have no other way of saying thank you. I remember that in a thing like this, many doctors, even if that is their specialty on their bread and butter, to be reluctant to make it with a short notice. And apart from that, presentations were so clearly laid out. I mean, they put a lot of effort. And on behalf of the college, I am saying thank you to both of you. My question is to Dr. Barnaby. Two of the investigations you mentioned was CT scan of brain and MRI. Both are quite important, but both are expensive. In the face of patients who really do not have the facility financially to support this investigation, which one should one choose of the two? Yeah, sorry,
yeah, well, as you mentioned, they are quite expensive in the clinic. When I was running the clinic, quite a high number of persons were unable to do these tests because of financial reasons. I probably would say to you that look at the clinical picture and see which one is better. Now, the MRI, depending on where you are, in Jamaica, they do have the MRIs that will definitely show you where the problem is, actually, and look at the other parts of the brain to see. Not hearing me at all? Oh, okay. That's what comes up having a very soft voice, not being heard. Yes, I was saying that a lot of the people at the clinic, they found that these other tests were beyond their reach, money-wise. And so they never did do them. We sent them off to do the tests, and they never did them, okay? Sometimes that was the spur for them not to come back to clinic. But I'm being asked to compare CT versus MRI. I would tend to go on MRI, but I would also like to confer with another person, a neurologist, in order to make that final decision. I like to work along with other persons in that regard. Psychiatrists don't usually send out people for CTs and MRIs, but they do it in consultation with another professional. I hope this answers the question somewhat. It's a collaborative decision.
Team approach. Thank you. Dr. Anthony Allen is online with a question, and then I'm going to ask Dr. Govia to give us more contact numbers, the Global Dementia Observatory, a 6-point questionnaire, how do we get them at the CCFP, and also on the World Alzheimer's Month, we'd like to get the contact numbers and how to, I chair the Jamaican Midlife Health Society, so I want us to do something collaborative with your group on that day. Dr. Anthony Allen, yes? Tony, you're online, you can go ahead.
He's muted, 1 second. Or unmute him, please.
Unmute your mic, Dr. Allen.
Unmute?
Yes, we're
unmute. Dr. Allen, have you unmuted your mic so we can hear your question? The presenters are waiting for your heavily loaded question. Yes? It was on earlier on. Yes, go ahead.
He's trying and I'm trying.
Speak, Dr. Allen. Okay, you're unmuted. No, still not trying to get in. Okay, Dr. Allen, you stop trying. Dr. Allen, stop trying and allow me to try to unmute you, please. Okay, you are now unmuted. Go ahead.
Yes, I'd like to express my appreciation to both Dr. Barnaby and Dr. Govia for excellent presentations. To Dr. Govia, the aspect of encouraging persons to make plans for their senior years, that has come out to me quite a bit. I have seen many cases where persons who are suffering from dementia are conned and actually treated very badly and exploited by family members, especially those who weren't around. And when they know the person has dementia, they already send trying to get money in various ways. And they, go to lawyers to say the person can't help themselves, etc. And then they become victims. And of course, as you said, once you make the diagnosis, the person can't apply for power of attorney. And you spoke about the springing power of attorney. So would it be useful to advise all persons in the midlife years, as you get older, think about your will, think about your living will, but also think about your power of attorney and springing power of attorney, so that if anything like this happens to you, you are well prepared in who you ask to look after your affairs. Your comments on that, please, Dr. Govia.
Thank you, Dr. Allen. I appreciate your question and your support, as usual. Yeah, I definitely think it's advisable. I recommend it more and more regularly in my practice, in my consultations, that people think about power of attorney and they put it in place. Either a durable power of attorney, which can start before any type of health condition manifests, or a springing power of attorney. Because all of these types of considerations are important as you are in this at-risk group. And most people in midlife, whether or not they're aware of it, because of lifestyle factors, they are at risk. And the later you take to put these things in place, the more you are actually burdening people who you don't want to burden later on in your life. And you're absolutely right in terms of how unscrupulous other people can be, even family members. And that's why it's important to have conversations before a health condition happens, to have ongoing conversations with family members about who you trust, who do you hold responsible. If you had to get into a situation where you needed to rely on somebody, who do you unequivocally trust? And it may be that you may trust one family member for some aspect and another family member for some other aspect. So you may feel more comfortable with your daughter bathing you and doing your personal hygiene, but you may feel more comfortable with your niece handling the finances, handling your personal finances. So it's important to think about that and to realize that different persons in your network could have responsibilities for different things. I hope that answers your question, Tony.
Thank you very much, Dr. Govia. Tony, I hope your question has been answered. We are running against time, 1 hour late. So we would ask Tekka Foster to come online. Foster, Dr. Foster, yes?
Hi, thanks for two excellent presentations, Dr. Govia and Dr. Barnaby. I have two questions. For Dr. Barnaby, in your presentation, you mentioned that they may have testing, or they do have testing available for example, if you have relatives of cases of genetic-based early onset Alzheimer's disease, where it can be detected a bit earlier. Is it easy for persons who, for example, who persons who do not live overseas to access these tests if they were to go there? And also, if it's detected where there's an early stage of it from these tests, is there any recommendation for use of acetylcholine esterase inhibitors where there's a strong genetic basis and that test shows that it is present?
Yeah, that's an interesting set of questions there. One of the things I say is that there's a school of thought that says that if you not to get tested, there's that school of thought, okay? And there's pros and cons to that. But in regard to genetic testing and so on, I'm not sure to what extent it is available here. But I know that abroad you certainly can get your test done if you really wish to. Again, I would say that if we're talking about the early onset type, where we know that it's probably one chromosome involved and then the genes on that chromosome is one thing. But when you have polygenic activity, which tends to be for the more sporadic type of the Alzheimer's, I am wondering, and I would like you to tell me what is it. I'm going to go on to the acetylcholine thing in a minute, but tell me what is your opinion regarding people having an idea beforehand as to what the risk is, and also if you could please tell me what you think is the role of prevention in regard to this matter.
Well, I think being able to plan is one of the things, as mentioned in Dr. Govia's presentation, in terms of a will, an active will, and just to really kind of plan an individual's future as far as that's concerned.
Of course, that's a reasonable thing. I'm not sure whether it's available, but in case, okay, the person, I would say to the person that they should be self-aware, the sense of you've gotten the test, you've found out what your genetic components are. And if you feel that you are at risk, you should test, because remember, the thing goes through stages. And if it makes sense for you to take one of the available agents at the time, then it would make sense. Okay? People actually do recommend that if you're going to be treating anybody for Alzheimer's or for another, well, let's stick to Alzheimer's, then the earlier the treatment starts, the better. The results are much better. And so in that respect, one could advocate for early treatment of acetylcholine esterase inhibitor. And then perhaps later on, if there is no good result from that and the disease progresses, then you go on to an NMDA antagonist. But you could really do it. You could really start with the acetylcholine esterase inhibitor, like the rivastigmine, which actually has very good efficacy with the alcohol-related persisting dementia. Rivastigmine is very good there, and we actually did some research on it some time ago.
Barnaby and gives some research and case study of that. Thanks.
Thank you very much. First, we are running 1 hour late. We have to proceed. We're going to do 2 presentations. One presentation, yes. You can go ahead with the sponsor H2K. It's on video. You can go ahead. Dr. Barnaby, please come this way. You can go ahead. No, we don't want to see her. It's okay. Just go ahead with the H2K. Okay. I'm just going to take a picture. Yeah, not this one.
Appreciate your talk very much. It's very relevant to what is happening in our society. We see patients on the borderline every day, and we have to be careful in choosing our words and we want to relate to caregivers and relatives. I think your presentation was absolutely well timed. I'm very happy that you could prepare in such a short time. Thank you so very much. I'd like to present this as a show.
Thank you very much. Go ahead with the H2K presentation.
Hi, good day. My name is Amoy Rickman, and I am a representative of Health 2000 Canada here in Jamaica. My other team member on the webinar today is Mardell Lear-Hyatt. So, Health 2000, better known as H2K, has been serving you and the public since 1999. I'm just going to share my screen with you now. Okay. All right, so Health 2000, we offer high quality generic pharmaceuticals as well as OTC products at affordable prices. To start, please allow me to address any concerns you may have about the FDA recall on 5 brands of metformin extended release for having too high levels of N-nitroxydimethylamine, or NDMA for short. H2K metformin does not fall into the FDA recall group. We did our due diligence with our manufacturer to verify and validate the safety and quality of our H2K metformin XR. H2K metformin XR does not have NDMA, so we urge you, please, to continue to place your trust in our company and metformin XR and continue to prescribe it for the benefit of your diabetic patients who rely so heavily on it. Who remembers Brown and Beautiful? Well, it's back. Introducing H2K Naturella 5-in-1 Cream, an everyday skincare cream for a radiant, glowing complexion. H2K Naturella has some key ingredients such as licorice root extract, niacinamide, lactic acid, and ursi leaf extract. This combination creates an awesome cream that leaves the skin feeling smooth and lubricated. Naturella removes dark spots, repairs uneven skin tone, prevents hyperpigmentation, moisturizes, and improves the tone and texture of your skin, while protecting it with its SPF 15+ UVB UVA sunblock. Naturella is hydroquinone free and is dermatologist recommended and is fairly inexpensive. Now, talking about awesome, there's another product here, H2K Borototal Neem Cream. This is your personal companion for wound healing and skin infections. The key ingredients in Borototal are neem. Neem provides a wide spectrum of antibacterial action. Aloe vera has anti-inflammatory and cooling properties. It soothes and forms a protective cooling barrier and speeds healing. Sesame oil treats inflamed, irritated, and damaged skin as it has a high antioxidant and antibacterial properties. Ashoka or Asaka is an astringent and helps reduce irritation and burning sensations in the skin. Licorice stimulates wound contraction for a better healing outcome, and zinc heals and rejuvenates the skin. This combination makes it your choice for wound healing and skin infections. So what can we use Borototal Neem Cream for? We can use it for cuts and scratches, diaper rashes, insect bites, blisters and burns, minor sunburn, dry cracked skin, skin inflammation, and sore nipples. For sore nipples, the nursing mother should use Borototal at bedtime and clean the breast before feeding. Borototal Neem Cream is locally recognized and effective for the diabetic dry foot, that thin, dry, papery skin that is prone to ulcers. We have had many success stories where this is concerned, even for things like razor bumps and eczema. So when you need to give your patients a herbal alternative, choose H2K Borototal Neem Cream, available as an OTC. However, you can also recommend it to your patients. Borototal is applied 2 to 3 times daily for as much as 3 months, after which you can decrease the dosage. To use it, wash and dry the affected area thoroughly and apply. Borototal Neem Cream, remember this name. You will be quite pleased when you try it. Just a brief reminder, our antibiotic, H2K azithromycin 500 milligrams, our SCASI, azithromycin oral suspension, H2K SCASI. H2K SCASI is a surprisingly good taste, offers a surprisingly good taste with its mint flavor, so your patients can tolerate this better. When there is wet cough, dry cough, any cough, use Dawa cough. Dawa means do away. Cough is cough. What a perfect name, Dawa cough. It's a mucolytic and expectorant as well as a bronchodilator in one great tasting syrup. It consists of salbutamol, bromhexine, guaifenesin, and menthol. It really works for the treatment of reversible bronchospasm, as in bronchial asthma, bronchitis, pulmonary emphysema, or just in the symptomatic relief of coughs and catarrh in flus, colds, and mild throat infections, and any chesty coughs. Now, all our products are available in pharmacies island-wide, so please write H2K before the drug name on your prescriptions, and please follow us on Instagram at Health2000JA and like us on Facebook. Just type in Health2000 Canada to find us. And last but not least, please connect with us to get your samples. Mardel covers part of Kingston, Portmore, Old Harbour, Manchester, and St. Elizabeth. Amoy, that's me. I cover part of Kingston, Linstead, part of St. Mary, and St. Anne. Chris covers St. James, Trelawney, Clarendon, Spanish Town, and part of Kingston. And Alma's, she covers Hanover, Westmoreland, St. Thomas, Portland, and part of Kingston. On behalf of my colleagues at Health 2000 Canada, we thank you for your support. Thank you for being a part of this webinar. We thank the CCFP for inviting us to participate, and we appreciate each and every one of you. Think safe, work safe, be safe. Thank you.
Okay, thank you. For those of you who don't recognize me or can't see me, within COVID restrictions, social distancing, and all the necessary things. We have, I'm mute again.
Okay, go ahead.
Okay, we've had a very good first session. I want to move right into the second session because we know we are behind time, but we are having some very rich interchange. Our next speaker, and keep on David. Yes, our next speaker is Dr. Julian McKoy Davis. He has a Doctor of Philosophy in Social Policy with high commendations. He is a lecturer, senior gerontologist, and the team lead for the community outreach at Mona Aging and Wellness Center at the University of the West Indies, Mona. Dr. McKoy Davis has extensive project management, adult education, and social gerontology experience, having worked in the aging industry since 2007. Her areas of expertise include social care and dementia, financial preparation for aging and retirement, as well as social policy and aging. She joined academia in 2014 and has published 8 peer-reviewed journal articles. She is a board member of the National Council for Senior Citizens and has professional memberships in the Gerontological Society of America, the Canadian Association of Gerontology, and the International Federation of Aging. It is our pleasure today to have Dr. McKoy Davis speak to us on effective caregiving. Dr. McKoy Davis, I know you're online. Over to you now.
Thank you so much, Dr. Standard Golson. Thanks for having me. I want to use the opportunity to say thanks.
Please unmute your mic. Okay, just hold on a minute because we're not hearing you this side.
Excellent. So she's free right now.
I think you should be fine now. You can go into slideshow mode and let's see if we can hear you here.
Hi. You're hearing me now? Is that better?
Yeah, we hear you in the physical room. The virtual room is hearing as well? Yes. Yes, good. You can go ahead. Thanks very much.
Okay, thanks, Dr. Standard Golson, and good morning to good afternoon to everyone. Dr. Seni and the CCFP team, thank you so much for inviting me to today's workshop. I want to also acknowledge the presentation from the previous presenters, Dr. Barnaby and Dr. Govia. So for my presentation today, I'm going to be switching gears and we're going to be looking at effective caregiving of persons living with dementia. Now, a lot of discussion has already taken place about the different types of dementia, and so I'm not going to go into that discussion. I'm just going to stick with dementia in general and to speak about caregiving in that regard. So one of the first things that I want to share is that the whole aspect of dementia is it's personal. It's sometimes very difficult for persons to be able to relate to dementia for persons living with dementia unless they actually have first-hand experience or they are aware of other persons having the condition. I also want to share that every experience of dementia is unique, it's different. And so we should not necessarily expect the progressions to be the same, but to be mindful of the fact that every experience is different. Having said that, I want to recognize the fact that for families, there are a number of challenges that the family will go through. And one of the biggest challenges include when it is that somebody who's living with dementia can no longer recognize family members and friends. That's very hard for a lot of families to cope with. It's also a difficulty for families, for example, when the person is unable to undertake their basic personal care. They're no longer able to toilet or groom themselves. That is something that is of concern, as well as when they lose executive function and so they're not able to make decisions on their own, as also when they start have problems communicating and so they're not able to communicate effectively. These are some of the challenges that families experience, that they go through. And sometimes when these challenges arise, it puts the family sometime in a ticklish position. We mentioned earlier in the previous presenters, they spoke about behavior, mood change, and different things. And so it can be a situation that is very difficult for a family to manage when other persons are around and they do not understand what is happening to the person who is living with dementia. And so they may go away with the wrong impression and even share experiences of what they saw that can actually taint the reputation of the person living with dementia. As much as families try to control and to put things in perspective, they are not always able to keep their relative or loved one safe from the eyes of the outside world. And so it's very important that that kind of education and sensitization is there so that persons understand what it is people with dementia, as well as their families, are going through as the disease progresses. And so we often hear about the concept of once a man, twice a child. It was mentioned in different ways in the previous presentations. I want to share that that concept is everything but the truth because of the fact that it strips the older adult of their respect, their dignity, their sense of independence. And why it is that we often equate an older adult with a child is that as they go through different medical conditions, such as dementia, then their level of behavior, their mannerism, their response is similar to that of a child. But we have to keep everything in perspective, that a child is a child and is in need of guidance and instruction and occasionally punishment For an older adult, it's a totally different situation where we have to be careful not to cross the line to start inflicting punishment that can be considered as elder abuse. So we have to be very careful about that. And so although the faculties of the older adult may be impaired as a result of the condition, we want to ensure that they are treated with respect. And so dementia is the single largest contributor of the need for care by older persons. Hence the role of the caregiver. Now, the caregiver is someone who is able to provide somebody who has a chronic medical condition with care as they are no longer able to care for themselves. And care happens in different ways, and depending on the stage at which the disease is, it may look differently. So for example, for somebody who is in the early stages of dementia, for example, they may not need the level of care that is required for somebody who is in the end stage. Somebody in the end stage, for example, may more than likely is bedbound or maybe using assistive devices and will need assistance, whereas somebody who is in the early stages, they may have problems remembering, and so other persons really need to be around to be more mindful and follow up and supervise them, which looks differently at different stages. Very often, a caregiver is a family member or a friend. The person sometimes is usually not formally trained, and they may not be compensated. And these are what we call the informal caregiver. There's a flip side of it where we have the formal caregivers, who are persons who are recruited through various means. They usually have formal training in terms of the provision of care, and definitely they are compensated for the provision of care services. And so caregiving doesn't happen in a vacuum, meaning it's not until when it is convenient for the family that care should be provided. Family members or persons around, because not everyone who is in need of care necessarily have family members around, but it's very important for others to be mindful of what it is that persons are going through to be able to determine when it is that care is needed. So for some, care may be something that is needed because of a sudden onset of an illness, such as a stroke. For others with more gradual or progressive conditions such as dementia, it's something that you may have to think through for a while and make that decision. But while we have caregivers coming into the picture, we recognize, as Dr. Govia mentioned earlier, that many of these caregivers are swamped with competing priorities. They are a part of the sandwich generation. So they themselves may have other family members that they're attending to, as well as this older adult who may be a relative, and multiple other responsibilities. And so I just want to introduce us to 6 basic types of caregivers. And these include 1, the primary caregiver. This is the person who basically sees to the day-to-day care responsibility of the person who is ill. And then we have the secondary caregiver, who is the person who provides backup care to the primary caregiver. And this person may be somebody who comes in on a weekend, or maybe persons running errand or assist with doctor's appointment. Of note, I want to indicate that in some situations, it's not just one person who fills the different category. You may have 2 primary caregivers. And depending on the stage at which the person is, you may have 2 to kind of balance out the level of care that is required. We also have working caregivers. These are persons who provide limited physical support, such as bathing or other routine tasks, such as payment of bills, but they maintain employment outside of the home. And so in some cases, they are also one of the primary or a secondary caregiver. We have what is called the crisis caregiver, and these are the persons who provide help in the event of an emergency. So for example, if there is the older person may have had a fall, or if there's need for hospitalization, then the crisis caregiver would kick in. We have the long distance caregiver. These are the persons who are physically distant from the exact environment. They may be miles apart, maybe a parish away or 2, or in a different country. And these persons work behind the scenes. They work towards the preparation and payment, for example, of utility bills, the payment of caregivers. They research healthcare needs, and provide information and options for the families. Very often, the long distance caregiver also contributes financially. The community is also a part of the caregiving network. And so the community caregivers are persons who engage the primary caregiver, for example, in fixing up the yard post-storm or pre-storm. They may help to batten up, they may assist with the delivery of mail, as well as other things as is needed by the caregiver. And so from Mona Aging and Wellness Center, as well as the Department of Community Health and Psychiatry, we conducted a study in 2017 where we looked at caregivers in Jamaica. And so a total of 180 persons participated in that study. Now, in that study, approximately 60% of the participants were close family members. So these are family members who are the primary caregivers. 64% of them had secondary level education, and less than 1 in 10 of all the caregivers had formal training in caregiving. So jumping back to a point that I raised earlier about family caregivers being very common, we also find that a lot of them do not have formal training in caregiving, and also it may also imply that a lot of them are not compensated for their caregiving roles. And so again, from these caregivers, they shared some of their experience about caring for their relatives with dementia. And many of them explained that they missed the warning signs of what was happening with their relative. In addition to missing the warning signs, many of them simply misinterpreted the signs. So they may have seen the person wandering, may have seen a particular type of behavior, and they would have misinterpreted that behavior to simply mean because, for example, the person may have retired, that they simply just want a break and they keep going in a particular place, or it's simply forgetfulness, or very often as persons want to say that being forgetful or having dementia or any of these mental health illness is a normal part of the aging process without actually recognizing that it's a genuine medical condition. And so as a result of having missed warning signs or actually misinterpreting those signs, many of them actually delay seeking medical attention. And so many of them simply learned by doing, as in they would have seen the different behaviors, seen the different things, but they simply found different coping mechanisms in which to deal with it. While for others, they would have been aware, they would have been made aware by a health practitioner, but they simply denied the situation. They could not, they didn't want to deal with the reality of what they were advised, and so they were in a state of denial. I just want to share an experience of one of the participants, who is a 52-year-old female who is providing care for her 80-year-old aunt who is living with Alzheimer's. And she said, "I feel very sad sometimes when I look at her and remember who she used to be. It's hard to accept that such a loving, caring person can come to this, saying and doing things she would not have done before she became ill. This is the hardest part of caring for her. I still can't accept it." So what we see, for example, in this expression is of somebody, a family member who is the primary caregiver. Also the fact that for her, it's a difficult situation for her to deal with caring for this family member who she can no longer relate to. All right, and this also brings out a point that is often referred to as ambiguous loss or grieving the loss of a loved one even while they're present. So the point being that here it is that she is in the presence of her relative, but she can no longer relate to who this person, her aunt, is. Her aunt no longer recognizes her. Her aunt no longer behaves like how she's accustomed to knowing her to behave. And so for her, the caregiver, it's very difficult for her to accept. She is in a state of denial. We see a number of things happening here. And so very often without information, without knowledge about what it means for somebody to have dementia, what it means to provide care, many persons who are providing care can in fact become stressed out because they, after a while, may experience difficulty in coping and in terms of how it is that they're able to provide care. And so we need to recognize that stress is experienced on an individual level and is person specific. And so there may be events that cause stress to one person, which may not cause stress to another person. And just to put that in context, in a caregiving setting, it is possible that a caregiver may have been providing care to a relative for 2, 3, 4 years, and for whatever reason, that person is no longer available, and a new caregiver is brought in. And within 2, 3 months, the new caregiver starts displaying signs of stress. And, you know, as family members looking on, you may be a little bit confused because you'll be thinking, well, the other one was taking care of mommy or daddy for all this time, and nothing happened. And so why is it that this new one just come and 2 months after they're already overwhelmed? As I mentioned earlier, stress is individual specific, and so people experience stress on an individual level. What stresses one individual may not stress another individual, and time frame has no limit in terms of what stress may look like in an individual. And so for some persons, they may be exposed to the same stressor, but in terms of the impact that it has on them, it may be short-term for one person, whereas for another person in the same condition, it may be long-term. The difference is in their coping mechanism. And so there are different indicators of stress. And so if the healthy behavior of a caregiver is impaired to the extent that they are neglecting their own health, care appointments, and eating a poor quality diet, then those are indicators of caregiver stress. You know, in a lecture I had in 2016, one of the things that I shared with the student is that our mental, emotional, and physical well-being can be easily undermined while providing care, because sometimes we are so bent on the provision of care for our loved ones that we provide little or no care for ourselves. And so I say that to say that for caregivers, one of the fundamental basis of caregiving is that for a caregiver needs to care for themselves first to be in a position, a good position, in which to provide care for someone else. If you can't take care of yourself, it then becomes very difficult for you to care for someone else. And so, question, what are some of the signs of stress overload? So some common telltale signs including when a caregiver easily snaps at a care recipient for no apparent reason. And they may become constantly irritated. They may express excessive anger. They feel constantly tired or pressured. They may have health problems or start displaying signs of depression. They may be losing sleep, yelling, screaming, or having crying fits, or rage frequently. They may start withholding affection. They may notice that they're not affectionate towards the person whom they should be providing care. So in terms of feelings of goodwill, they don't have or express that. They may not be bathing the care recipient frequently or dressing them. Another thing of note is when the care receiver is constantly being blamed for the caregiver having to be in the position of having to provide care. And this happens a lot if it is that the caregiver is a family member. When it is that the person is a formal caregiver, then you won't really get that kind of behavior. But typically in an informal setting where it is a family member, for example, a child having to take care of an aging parent, then you may see that kind of behavior, as well as refusal on the part of the caregiver to go out and interact with friends as before. And so this kind of stress can lead to caregiver burnout because it has now become so overwhelming. It's beyond the capacity of the caregiver to provide care. And so the level of burden perceived by the caregiver is not, as I mentioned earlier, is not necessarily associated with how long it is that the person is in the position of providing care, as well as not necessarily dependent on the progression of the illness, but may just be that after having done so little or so much, it is now beyond the capacity of the caregiver to provide the kind of care that is required. And so it's very important for family members as well as others to be mindful of what is happening with the caregiver. And by saying family members, we have to be mindful that, as I mentioned earlier, the caregiver may in fact be a family member, for example, a spouse. And so identifying when there's stress and there's burnout is good. So it's good to recommend the professional help. Also encourage the person, for example, to take a break. And this is where other family members can get involved to kind of relieve the responsibility from the primary caregiver. So other family members need to start chipping in, as well as community caregivers can chip in to give the primary caregiver a break. So in so giving them a break, it gives them the opportunity to relax, to be themselves, to unwind, to do things that they enjoy, and also for them to reconnect with friends. There comes a time in caregiving when it's important to make a decision if we should continue with the caregiving arrangements as is, or to stop caregiving. And as I mentioned, caregiving can be extremely stressful, and stress has been indicated as something that contributes to medical complaints, including migraine, headaches, high blood pressure, and may also have a role in increasing an individual's susceptibility to heart disease, stroke, and cancer. And so family members need to be aware of what is happening with their caregivers and encourage their caregivers to explore whether or not they should continue with the provision of care. Now, when it is that the caregiver is a family member, it can become a bit difficult because sometimes, for example, a long distance caregiver may not fully understand what it is that the primary caregiver is going through, and may the long distance caregiver, for example, may feel overwhelmed, thinking that, hey, you know, I'm the one who's working, I have to be working to get all of this money to assist the primary caregiver in the provision of care. But for the primary caregiver who is there on a day-to-day basis, having to provide care, having to turn this person, have to assist with toileting, with feeding, then the level of stress on that person is totally different. When the primary caregiver, for example, is a spouse or a child, sometimes there are feelings of guilt, of not wanting to consider the option of no longer providing care, of the possibility of having to institutionalize this relative, of the possibility of requesting formal caregiving. This is something that as a family, as loved ones, as relatives connected with the care recipient, they need to take the time out to have that kind of discussion and recognize when it is that the caregiver's health is at risk for having, if the caregiver continues in the current arrangement. There are anecdotal references to the fact that some caregivers actually die before their care recipient because of being overwhelmed and not getting appropriate care for themselves. So that is something that family members need to be mindful of so that the appropriate action can be taken. And so for caregivers who must continue caregiving, even if it is that they feel overwhelmed or burnout, it's important, as I mentioned earlier, to identify different ways and means of taking a break. And taking a break, for example, may include the use of respite services. So for example, this may be short-term or temporary care in which someone may come in to provide that care, or it is possible that you may occasionally send the care recipient to a facility or someone for a short term, just to give the caregiver a break. Also seeking additional help and support. And it's, as I mentioned earlier, very pertinent for the caregiver to attend to their personal health and well-being. And so some quick caregiver tips. Each care recipient is different, and so care should be developed accordingly. It should be person-centered care, as Dr. Govia mentioned. The historical background of the care recipient is very important and is a good indication of the type of care or what it is that care should look like, the kind of care need that is most appropriate for the care recipient. So for example, if it is that the person was a farmer, then it would be good to include some kind of gardening, something for them to be engaged with, even although they're within the home setting. Dr. Govia also mentioned the use of music and poetry, different things to be able to engage them. Caregivers should not be afraid to ask for help, and most importantly, in asking for help, they should be willing to accept the help. And their health and well-being is as equally important as the care recipient. So if all the concern is on the care recipient and none on the caregiver, we may start having problem in the near future. And so for family members, it's important to discuss and address estate planning issues from early. And it's not about being morbid and or wanting our relative dead, but it's making good decisions. And why I say so, because as disease progresses, we understand that there are difficulties in communication. They're no longer able to express their wishes. In terms of preparation of a will, if that is not done early in the day, then that kind of understanding in terms of what it is, where the wishes of the relatives can no longer be deciphered. So the person may in fact die intestate, and that becomes difficult for families to manage thereafter. We want to address issues as it relates to advanced care planning. What should be done in the event of the person having an emergency? Should we consider hospitalization? Should we consider institutionalizing the person? Or what are the final wishes of the persons? For example, if the person is dying, do they want to be placed in a hospital in which aggressive medical attention can be sought? Or would they prefer a more palliative care approach in which they are at home, for example, in their personal space, and they have requisite support, for example, just to facilitate pain management and the support of their families? Also, we want to encourage family members and relatives to be in the present. And by being in the present with the relative, it's to acknowledge that it's quite easy that the relative may have problems with time orientation. And so they may easily take you back to 30 years in time, even to time before you were born. The point is, it's okay to take that journey with them. And if possible, to document that journey. And I'm saying that because sometimes as the person nears the end of life, you may start wishing you had those times again when the person was just being repetitive and talking, and all of that repetition was annoying you, but you didn't recognize that those were memories and treasures that were being shared with you. If it is that family members don't engage the relative as they are talking about their experiences, as they're going back, as they're having different flashbacks and memories, it can lead to agitation. And so you want to minimize that as much as possible. You have to develop different coping strategies. Families also, I mentioned earlier about experiencing ambiguous loss or grieving the loss of the person while they're still alive. This is something that it's important to recognize that it is normal. It's not strange for you to have the person right in front of you and not be able to relate to what the person is going through and just feeling very, very sad and go through a process of grief. That is normal. You want to help the person who is living with dementia to remain as active and independent for as long as they possibly can. So even if they're having a meal and they're not able to feed themselves properly, it's okay. Allow them to be able to use a fork or spoon, whatever is safe, as much as is possible. For some, they may have problems, for example, gripping or holding instruments. And so if it is that you add additional things, I mean, one of the things that I was taught is that the hair rollers that women used to use in their hair as setters years ago, that can be used, for example, to be placed on a fork to assist the person with hand-holding grip. So you want them to be able to have that level of independence as much as possible. The relative with dementia needs your constant reassurance and love. And having said that, you want to love them irrespective of the surprises. So some of the surprises, they may be cursing, they may be using harsh words, there's no sense of inhibition and something that you can't relate to, that this is not the mommy or daddy or auntie that I knew before. And so some of these experiences with them can be very painful and hurt, and something that really hurt you, but you need to recognize that this is no longer the person that you knew them to be. And many of them are no longer aware or in charge of their faculties. So love them irrespective of the surprises. For health practitioners, there's a role that can be played. Dr. Barnaby mentioned some of the warning signs before that shouldn't be missed, and the different instruments and scales that can be used to assist them in the process to be able to recognize what is happening from early. But health practitioners also have a very crucial role in terms of increasing awareness about the condition, helping family members and caregivers as they go through to understand what is happening, and not just what is happening at the point of diagnosis, but to help the family to understand the natural progression, to give them referrals to other health providers who may be able to assist them in the process, as well as to share other resources from which they can get information. We want to encourage the caregivers to take care of their own health, something that I've been harping on throughout this presentation, in order for them to care effectively. And where possible, for health providers to facilitate dual checks of the caregiver while the caregiver is in the facility to take care of the health of the care recipient. Having said that, I am conscious that within the context of COVID, it presents some challenges for someone who is actually living with COVID. And so they may be concerned about why it is that everybody around them is wearing a mask, whether or not it is that persons are scorning them. So that dialogue needs to be had with the care recipient to help them to understand what is happening. And yes, although you may share that dialogue, it's a dialogue that you may have to have with them several times because of the nature of the illness. It is possible that there is a need for change in the caregiver, especially during this time. And so as families, as friends, you have to walk both the caregiver and the care recipient through this process, because it's not an easy process when there are transitions. Also not easy, for example, if there are transitions, as Dr. Govia mentioned, from one location to the other, that can have serious impact on the health and well-being of the care recipient. And the fact that routines may have changed significantly as a result of COVID-19, especially given the context of the stay-at-home orders. So for persons with dementia who were still ambulant, now having been restricted to stay at home, many of them may have become very frustrated and feel a bit isolated or don't understand what is happening. And so there is a need for others to become very engaged and to support them through the process of what is happening. So in closing, I just want to share the fundamentals of effective caregiving of someone living with dementia is that knowledge is key. Knowledge, first and foremost, is paramount for persons in order to be able to provide the kind of care, the quality of care that is required for persons living with dementia. So it's important for caregivers, for family members to be aware of what is happening and the kind of care that is required. Patience and tolerance are two virtues that will be required on a very regular basis, constantly asking for grace and patience, tolerance to deal with the care recipient, because you may see different behavior, mood swings, different things that as the caregiver, knowledge will help you to be able to minimize as much as possible unwanted behavior. Also know that persons who are living with dementia are not always aware of what is happening. They're not always in charge of their faculties. And so family members need to be aware of that. Very often, for example, when there are certain types of behaviors such as spitting or biting, it's very easy for persons to just give a slap just as you would a child. And then after a while, that slapping turns to beating. And the argument is, for example, that they are fully aware, they know what they're doing, they know they're not supposed to be doing this. I mean, you know, you always taught me as a child that I shouldn't do this, so why are you doing that? Be mindful of the fact that with dementia, they are not aware, the brain no longer processes the actions as though it would have pre-dementia. And so family members and caregivers need to devise different coping strategy in order to be able to deal with situations as they arise. And in terms of dealing with situations, they also have to be mindful of protecting their relatives and loved ones from persons who may not understand and may in fact affect the reputation of persons as they know it. And this sometimes can be very unfortunate for family members, because for many family members, what they simply do is to basically isolate their relative from the world, to shield them and protect them, because they simply think that persons don't understand what is happening. And that is why knowledge is key, to be able to inform yourself as well as to inform others, so they understand that the behavior that is happening is not the norm, it's not the person as they know it. Adequate support system to be able to provide care and support to the caregiver and recipient is also very important. And relatives and family members need to be updated very regular about what is happening with the care recipient. Finally, I want to say that it's good to be able to recognize when the caregiver is stressed or showing signs of burnout, because that ultimately affects the quality of care that is provided to the care recipient. Just want to say thank you, and I'm from Mona Aging and Wellness Center, as shared before. You may feel free to contact us for more information. Thank you so very much.
Thank you very much, Dr. McKoy Davis. I know there might be some questions that have been, thank you very much, Dr. McKoy Davis. I know there might be some questions that are generated, but we're going to hold those until after the next speaker. I know that, I believe Dr. Mark Taylor is in the room. I'm just going to introduce him at this point. Dr. Mark Taylor is a cardiothoracic and vascular surgeon, Jamaica born and recently returned home. He graduated from the University of the West Indies and later interned at the Cornwall Regional Hospital. He completed a residency in general surgery at the Howard University Hospital, a fellowship in surgical critical care at Mayo Clinic, Rochester, Minnesota, and a cardiothoracic fellowship at the Wayne State University in Detroit, Michigan. Dr. Taylor was also a clinical associate at the Cleveland Clinic Foundation in Cleveland, Ohio, and a cardiothoracic and vascular surgeon at the Samaritan Health Services in Oregon. He also is certified by the American Board of Surgery in General Surgery and by the American Board of Thoracic Surgery in Cardiothoracic Surgery. So it gives me great pleasure to welcome Dr. Taylor to speak to us on vascular dementia. Dr. Taylor. We're seeing your slides. It's not in slideshow mode yet. You're unmuted now.
Hello, good afternoon.
Afternoon. You can go ahead and put in slideshow mode.
Okay. Alignment. Where is this stupid thing?
I'm told you can press F5 on your keyboard. F5, F5.
Good.
slideshow. There you go.
Okay. Hello, good afternoon. I'm waiting for my, there we go.
It's coming up. You can go ahead.
Yes, just a minute there. I need to get back to my first slide. Okay, good afternoon. My name is Mark Taylor. I'm a cardiovascular surgeon. I have an interest in vascular dementia, and I am aware of the situation in Jamaica. Where I practiced before, we were very much more proactive in terms of vascular dementia, because it is probably a very small section, maybe 20% of the dementia population, where another small percent of that 20% is probably treatable. And also the fact that there is aggressive risk factor modification available for patients with dementia, with vascular dementia. Okay, good. So, what is vascular dementia? Well, vascular dementia is a vascular disease or arteriosclerotic disease of the cerebrovascular circulation that results in dementia. And it's basically blockage, but also hemorrhagic disease can result in dementia. And it starts, from the carotid, but plaques in the aortic arch or even the heart, or clots in the heart that embolize, will result in damage, and over time multiple small or strategically placed embolus can result in dementia. The most common problem is intracerebral disease, which is small vessel disease. The only thing that is really treatable is carotid artery disease, which probably does not account for a large percentage of these patients, but it's the one that is treatable surgically, that can be fixed. This presentation is more just to create an awareness. I'm not a dementia expert, but in terms of risk factor modification and being aware of vascular dementia as a significant proportion, as the second most common cause of dementia. In most cases, won't be able to do anything, but as we go through, you will see what we're talking about. So there is multiple different types of vascular dementia. There's multi-infarct dementia, that is multiple strokes. That's the one that is particularly of interest to a vascular surgeon, because carotid disease can result in multiple CVA and in multi-infarct dementia. Very often there is imaging that shows no real carotid disease in a patient who clearly has multiple infarct disease, and you can't find a site. In these cases, it's the aggressive risk factor modification with blood pressure control, diabetes control, statin, and antiplatelet therapy is all you can do, but that should be maximized. Other types of vascular dementia is the a strategic infarct, or lacunar infarcts are pretty common. Not necessarily, I think, as you get older, you see these, it's not always associated with dementia. Subcortical or Binswanger disease is more a subcortical lesion that results in dementia. And of course, there is mixed dementia where there is Alzheimer's plus vascular disease. This is a little presentation to kind of create awareness of what to look for. The history is an 82-year-old female with rapid decline in cognitive function. This has happened over 2 years, which is pretty rapid. Initially, there was memory problems. And then a year ago, there was this episode with sudden confusion, slurred speech, which was probably well, we'll get to that, but that's a CVA. And then there was worsening confusion. The past medical history, significant for diabetes, hypertension, and of course, medication is there. Cognitive testing, mini-mental status exam, clock test, verbal fluency. That's the usual thing that was done. Physical examination of importance is that in vascular dementia, it's more likely to have a neuro deficit. It's more likely to find something as opposed to other type of dementia. There may or may not be a localizing neurological sign. CT or imaging is very important, and we'll get back to imaging for vascular dementia. But as you know, as you get older, whether or not you have dementia, it's very likely to have findings on the CT, whether it's shrinking of the brain or small strokes. But in a patient with vascular dementia, it's very likely to have both of those findings. All right, in this patient, and this case was chosen because it has features of both Alzheimer's, it has features of vascular dementia. The specific features of vascular dementia is the episodes, the acute episodes, which are probably stroke, the findings on the CT, and the most important thing is the stepwise decline in cognitive function. The rapidity of decline is also consistent with vascular and mixed dementia. So there are different types of vascular dementia, and as I mentioned before, there are also more the neuropsychiatric manifestations are more specific and are more linked to vascular dementia than Alzheimer's disease. It is more it progresses more rapidly. Patient is at risk of needing institutional care more quickly than Alzheimer's disease. And of course, it's usually associated with considerable morbidity because of associated vascular disease, which has the underlying risk factors: hypertension, diabetes, smoking, hypercholesterolemia, that kind of thing. Okay, so the history is just important to note that vascular dementia is not a new diagnosis. In the 70s, it was identified as the most common cause of dementia, and at that time before that in 1910, the term arteriosclerotic insanity was coined. Today, Alzheimer's is more common Western disease, but in Asia, vascular dementia continues to be the most frequent type of dementia. Okay, so Alzheimer's disease accounts for at least 60% of dementia, and vascular dementia is 10 to 15 or 15 to 20%. The rest are all at or below 10%, unless you're in China or Japan, where it is the most common cause of dementia. One of the hallmark of vascular dementia is depending on exactly where the lesion is, you can get very specific symptomatology or very specific findings. And one of the big issue in multi-infarct dementia, sometimes you're able to show specifically lesions in the language area, and it's very common because of the blood, the circulation that is, or the arterial supply to that area. That language plays a big role in, or has an outsized role in the diagnosis of vascular dementia, or not real language, but language deficit or language disorders. Focal cognitive deficits are not necessary, but much more common than in Alzheimer's. And of course, with frontal infarction, there's impaired executive function, which is similar to Alzheimer's. As I've said before, is that focal neurological signs such as weakness on one side, a specific speech, difficulty with speech, those are neuro deficits, and those strengthen the diagnosis of vascular dementia. Okay, on CT, there was discussion of CT MRI before. MRI is probably more early in a CVA. MRI shows the area of infarct quite early. As it progresses, though, the CT does pick up. But for vascular dementia, we're specifically looking on vascular imaging. Now, with both CT and MRI, you are able to see the carotids, the internal, in the siphon up to circular Willis, anterior and posterior cerebral vessels. So both gives you pretty good visualization of the vasculature. Off note is that, and this is probably the most important thing, I think, is that for imaging of the carotid artery, you only need a duplex. All the major studies that were done initially connecting carotid disease with CVA, TIA, and we think that also vascular dementia, they were all done with carotid duplex, not with CT or MRI. So for carotid disease, it's a duplex. If there is no significant disease on carotid duplex, there's no need to get the CT. For the carotid, should you get neuroimaging to make the diagnosis of vascular dementia? Well, there's no real intervention apart from risk factor modification for intracerebral disease. So if you're curious, but in terms of it making a difference, I don't believe that it actually does. Okay. So they are different presentation for vascular dementia depending on what area of the brain is affected. So it gives you different neuro and behavioral disorders. But there's also a different way of looking on this, whether it is large vessel disease, small vessel disease, or whether it's due to ischemic hypoxic, which is more like a general, more like a closed head injury, and of course there is hemorrhagic. For large vessel disease, it's usually middle cerebral, anterior cerebral, or posterior cerebral, and it usually presents as a post-stroke dementia. That is, patient had classic stroke, and on recovery, or physical recovery from the stroke, then it's noted that the patient has developed dementia. Of course, it's more common with multiple stroke, but a single strategic stroke can cause that problem. So specifically in the CVA population, you have to specifically look for signs of dementia, status post CVA. And of course, this is probably the easier, I have easiest up there, but I would say the easier diagnosis to make because of the relationship of the CVA followed by signs of dementia. And as I said, large vessel disease is usually the most commonly something from the middle cerebral, whether it affects the anterior or posterior cerebral vessel. Those are big vessels and they result in a stroke. The most common one is a middle cerebral. Okay. The treatable disease in cerebrovascular disease is carotid artery disease. I have noticed in Jamaica, since I've been practicing here about 2.5 years, that there is kind of there's a difference. I don't have the information on the cerebrovascular circulation, but I have documented it clearly in the leg where there's extensive tibial disease. The femoral artery from the groin to the knee is open. And there might be some irregularity, but there's no SFA, superior femoral artery stenosis or occlusion. That is the most common pattern in the US. So you, as a vascular and endovascular surgeon, you do a lot of femoral stenting or fem bypass. Here in Jamaica, the disease is so different that over 2.5 years, I've done 2 fem pops, multiple fem to distal bypass. So what I am putting together in my practice and thinking about is that it is probably the same pattern in the brain where there's not extensive carotid disease. The carotid artery and the femoral artery are about the same size, 5 millimeters, 6 millimeters. The intracerebral vessels are probably the same size as the tibial, which is 3 millimeters. So my idea is that that's the type of disease that will affect the cerebrovascular circulation here in Jamaica based on my observation in the leg. And the reason I feel very strongly about this, and the reason is that it's so it's so different. I mean, I will go through 10 patients in a row with severe peripheral vascular disease, gangrenous changes, and the femoral artery is completely open. All the disease starts at the knee. It's very stark to what I'm used to. So I'm thinking that maybe there's something going on with the brain. This is an example. The bottom slide show that it's the femoral artery coming up to the trifurcation. Looking on the lowest picture here, this is the anterior tibial, this is the tibio-peroneal trunk. Now the femoral artery is completely normal, and then going down the leg, it's severe disease. The dorsalis is open. This patient actually had a femoral to dorsalis venous bypass. But this type of extensive disease is what I see here in Jamaica, which is very unusual with a normal femoral artery. So I think this might be what affects the brain too. So if I am extrapolating from the leg, kind of dangerous, but the femoral arteries are the same size as the carotids, and the intracerebral vasculature are the same size as the tibial. So I just haven't been able to put everything together to actually write a paper on this, because I don't have the extensive cerebral vascular imaging that I would need. So anybody want to volunteer to help or collaborate with me, I'd be very happy to do that. Okay. Let's get back to what we're supposed to be talking about. We were at post-CVA dementia, and the incidence of dementia after stroke is as high as 25 to 41%. This is 3 months after, and of course the clinical features would depend largely on what part of the brain was damaged. But a very important aspect of the post-stroke dementia is depression. And the reason depression is such a large part is that patients are aware, and they are aware of the limitations, and they get very depressed. And of course, the location of the lesion is a lot more important than the size, unless it's, of course, a very large infarct. But even in that case, the location is the most important thing. Okay, why do some patients with stroke have cognitive impairment and others don't? Well, it's a part of the brain that is damaged, of course. But there are other risk factors: age, recurrent stroke, and of course left hemispheric stroke. And if the stroke is associated with trouble swallowing, or if there are gait changes or urinary incontinence, those indicate that there's a higher risk of dementia based on the part of the brain that is affected. Acute complications of a stroke, whether it's seizures, arrhythmia, aspiration, all of these can cause further damage to the brain, which can increase the risk of a post-stroke dementia. Okay, small vessel disease. That was large vessel disease. Small vessel disease is more involvement of the more distal vessels. For example, the size of the tibials that I mentioned before. This is more peripheral in the brain, and it affects the frontal lobe, not only, but it's very pronounced there. And the result is that there is significant executive dysfunction, inattention, depressed mood, change in gait, Parkinsonism. All of these are big part of small vessel disease because of the effect on the frontal lobe, whereas memory impairment is less pronounced. So lacunar infarct, which is common. All right, mixed dementia is probably, I don't know, I'm not a dementia expert, but I'm told that mixed dementia is also very common, where there are vascular lesions associated with Alzheimer's. And even if you have a diagnosis of Alzheimer, if there's neurodeficit, then it is probably associated with vascular dementia. An important aspect of vascular dementia is the association with neuropsychiatric symptoms. They have and because of this, they have a higher risk of requiring institutional care than patients with Alzheimer's. And that is, of course, because of the behavioral and psychological syndromes that they develop. And with the distal small vessel disease, specifically the frontal lobe, which is responsible for complex social behavior, initiative, forethought, and behavioral adaptability. So those are the things that are affected, and those are the things that make us human. Okay, as I mentioned, the post-stroke depression is a large part of, or a significant problem associated with vascular dementia. Not just vascular dementia in general, but large vessel disease or post-CVA dementia. It is more common with less, as we would expect, with a less hemispheric stroke. It's harder. It is probably harder to figure it out why in a patient with a right hemispheric stroke, because of their difficulty with emotional tone and speech. So it's harder to communicate with that patient. Off note is that most of the cases are undiagnosed. So the important thing in the post-stroke patient is to look for one, dementia, and if there's dementia, to look for depression. Some of the important symptoms associated with this post-stroke dementia is listed here. Patients are, and the depression associated with it is tearfulness and sadness, and the neurovegetative symptoms where there is changes in their sleep pattern. They may be sleeping continuously during the day, maybe awake at night, or there may be loss of energy. You know this more than me, but this is just an awareness to specifically look for these findings in the post-stroke patient. Then comparing Alzheimer's disease with large vessel vascular dementia. The difference is, one, is memory. Is Alzheimer's memory is affected in frontal lobe or large vessel disease? The memory is intact, but there is more neuropsychological behavioral problems. That is the big difference. If there's one thing that you should remember, is the difference between the memory deficit in Alzheimer and in large vessel vascular dementia. There's the memory deficit can be there, but it's not prominent. What is prominent is the neuro and behavioral deficits. Okay, the risk factors, of course, is hypertension, diabetes, hyperlipidemia, age, yes, but everybody gets older, gender, males higher, race, and etc. The only important thing on those risk factors is risk factor modification. And it's the same for any vascular, cardiovascular disorder anywhere else in the body, which is statin, antiplatelet drugs, aggressive cholesterol control, blood pressure control, diabetes control, smoking cessation. But in this case, you're specifically addressing the risk in the patient with vascular dementia. Diagnostic tests, of course, as so eloquently described initially, the mini mental status exam is very useful for dementia. Unfortunately, it is not as good in patients who have vascular dementia because their problem is not memory so much, or it's a lot of behavioral problems that they might have. They do have finding that you'll pick up there, but probably the Montreal Cognitive Assessment MOCA test is probably more appropriate since it was specifically designed for this. And this is what the testing looks like. And then we get into the general, this was discussed at length before, no reason to go over that. And I will end there.
Thank you very much, Dr. Taylor. Thank you very much, Dr. Taylor, for that presentation.
Thank you.
You told us a little bit about patterns of vascular disease and also some of the tests that introduce us to a test that is more sensitive for vascular dementia. Dr. McKoy Johnson earlier told us about not only effective caregiver for the care recipient, but also emphasized the importance of caring for the caregiver. I'm sure that both these presentations have generated some questions. I'll ask you if you're online, if you could raise your hands. Is there anyone in the room here with me who would like to ask a question? I see that Dr. Williams-Green. Okay, I'm going to take online first, and I see one in the room as well. Dr. Williams-Green, you may go ahead and ask your question.
Good morning, and thank you for excellent presentations from both presenters. Dr. McKoy, Davis, you triggered a thought, or you reminded me of a patient when you were speaking about the COVID effect. I had a 92-year-old male who obviously has his problems. He's hypertensive. He would visit his 20-day trip and play dominoes with his cronies at the same age. But then came along COVID, and he was told to stay at home. And he was there for 3 months. And now his relatives brought him in because he was doing strange things, you know, going in the drawer and taking out stuff and putting wrong things in the drawer, acting strangely. My examination was, you know, same as usual because I know him very well. And I thought he was having some kind of cognitive problems because not so much of dementia, but because I think he had been locked up for the past 3 months. Your comments, please.
All right, thank you so much, Dr. Williams-Green, for that question. And you, more than likely, you are correct. It is a fact that with persons being under lockdown or stay-at-home orders, it borders on an isolation for a lot of them if it is that family members are not engaging them. And so it's very difficult for them to deal with a situation as in a lockdown setting. And for us in Jamaica, yes, the stay-at-home orders have lifted, but lifted for a particular age group. So the 75 and up are still under stay-at-home orders. It therefore means that going forward, families need to do more. Communities need to do more to engage the older adults, because studies have shown that older adults who are isolated for a long time, then there can be negative implications. So as much as possible, there is need for that kind of engagement. Yes, they don't have the opportunity to go outside as regularly as they would have wanted, but we need to see how much we can take outside to them. So I agree with your
Thank you, Doctor.
You're welcome.
Thank you, Dr. Davis. Dr. Onanuju, you have a question, and then I'm going to go back online to Dr. Robinson. Dr. Onanuju is coming to ask a question.
Julian, McKoy, Davis, thank you very much for your excellent presentation. I'm sure we all profited from it. However, I would want to find out from you, if you don't see some family members who treat their demented patient badly, just because either because they think that he doesn't have the brain that he used to have before, or they feel that that particular individual should not be there because it's not good enough, although that particular individual could have been the one that put in all the facilities that they are enjoying. And when we notice this, how do we as doctors deal with the family members?
All right, thanks, Dr. Onanuju, for that question. The fact is that we do have the situation of family members, and the truth is you can't trust everybody. It would ideally have been good to know, for example, the family before or watch the family throughout the process of the person having the condition. But the truth is that you won't actually know everybody necessarily. Behavior of family members are a good indication of what is happening because they sometimes give themselves away. But it is sometimes difficult because sometimes the family member that comes to you that portrays this very positive image is actually the ones who have some ulterior motives in terms of what they are doing. You see, for example, you see a lot of that happening closer to the end of life. Everybody is rushing to say they need to get the family member seen by a medical practitioner because, and that is an indication, for example, where there's conflict in the family, that this family member, for example, wants to take charge of burial expenses because there are other implications of them being able to access other funds. And so sometimes it's very difficult in terms of how it is that you deal with family members. But in terms of the quality of care that is provided to the relative, that also is a good indication of who is a genuine family member as opposed to somebody who is there for personal gains and ulterior motives.
Thank you very much. Dr. P. Robinson, you can unmute and ask your question. He doesn't, you don't need to have a microphone.
He needs to join with audio.
You need to join with audio, Dr. Robinson. Failing that, you could go ahead and type in your question and we'll read it out. In the meantime, I'll go on to Dr. Martin Taylor. You can open your microphone and go ahead.
Morning. General Practitioner Montego Bay. This question might be of academic interest more so, but in our Chinese population in Jamaica, how often do we see vascular dementia in them?
Dr. Taylor, I take it that is is Derek poor? Well, having just been back for 2.5 years, it might be.
I don't know.
It might be difficult.
I don't know. Sorry, but that one I don't know.
That is something that we'd have to do some research on.
Yeah.
Maybe something you'd want to take on. But just before you, since we have you here, taking moderator's privilege, so am I to understand, in terms, you talk about risk reduction for vascular dementia. These are the same kind of risk reductions we do for all vascular events. Is that so? Or is there anything specific?
Yes, absolutely. But there is one specific thing with vascular dementia, and is not going overboard with the blood pressure. You want to avoid orthostatic hypotension, not at all costs, but you really want to be aware of that. So aggressively treat high blood pressure, but do not cause hypotension, because they need that extra cerebral perfusion pressure.
Thank you for that, because oftentimes with all the different guidelines coming up, we are encouraged to bring the pressure down as low as possible, but we have to remember in the older persons that they do need that amount, a little bit of perfusion.
Mm-hmm.
All right, are there any other questions in the room, online? Dr. Robinson, I don't know if you have had time to type in. If not, you took your hand down. Okay. All right, if there are no other questions, I just want to thank our two presenters, Dr. McKoy Davis and Dr. Taylor, for taking the time out to present those two excellent papers to us and giving us more food for thought. We're going to move on now to our sponsored presentation, which is sponsored by the Samaritan Cardiovascular Services. And our presenter is Ms. Latifah Hudson. Ms. Hudson is a registered physical therapist and a practice manager at the Amputation Prevention Center, Samaritan Cardiovascular Services. She is a graduate of the University of the West Indies with a BSc in physical therapy and recently received certification in hyperbaric oxygen therapy. Her goal is to raise more awareness in Jamaica surrounding the importance of physical therapy, along with the many benefits of hyperbaric oxygen therapy, which has been proven to be beneficial for COVID-19 patients. So we're very interested to what Ms. Hudson is going to tell us about hyperbaric oxygen therapy. I believe you are online, and I'm going to hand over to you now. If you can unmute and open your video.
Hello, good afternoon, everyone. My name is Latifah. I'm a registered physical therapist, and today I'll be presenting on hyperbaric oxygen therapy. So today we'll be looking at the definitions, the history, principles of hyperbaric oxygen therapy, the physiology, the mechanism of action, dosage and delivery, types of chambers, indications, contraindications, preparation before hyperbaric oxygen therapy, the negative effects, complications, and then we'll have a conclusion. So firstly, we look at the definition. What is hyperbaric oxygen therapy? This is a medical treatment in which a patient breathes almost 100% oxygen in an enclosed pressurized environment. Atmospheric pressure is increased above 1.45 ATA to achieve the hyperbaric environment. We will now look at the history. In 1662, the first hyperbaric chamber was built by Henshaw. He called it the domicilium. It was used to treat multiple diseases. The chamber was pressurized with air and unpressurized with bellows. In 1775, Joseph Priestley first discovered oxygen, but it wasn't until 1777 when the name was coined by Antoine Lavoisier. In 1879, the idea of treating patients under increased pressure was continued by French surgeon Fontaine. He built a pressurized mobile operating room. In 1928, Dr. Orville Cunningham, a professor of anesthesia, ran what was known as a steel ball hospital. This structure was 6 stories high and 64 feet in diameter. The hospital could reach 3 atmospheres of pressure. It was closed in 1930 because of the lack of scientific evidence indicating that such treatment alleviated diseases. In 1937, Bettany and Shaw first used hyperbaric oxygen successfully for the treatment of decompression sickness suffered by deep-sea divers. And in 1950s, modern clinical application of hyperbaric oxygen began in parallel with an increased understanding of blood gas analysis and gas exchange physiology. We now look at the principles of hyperbaric oxygen therapy. Now, based on how gases of different solubility, most importantly oxygen, how it behaves under changes and volumes within tissues and fluids. We have the Henry's law, Dalton law, and Boyle's law. Henry's law states that the concentration of dissolved gases equals the pressure times the solubility coefficient. This explains how gas subjected to pressure is diluted in liquid, and in this way we'll understand how oxygen diffuses to plasma independently of hemoglobin. Dalton's law explains that the increase in partial pressure of oxygen is the sum of partial pressures of each gases that make up the formula. Then there is Boyle's law. This relates to how the volume of gases behave under pressure. With increasing pressure, the volume of gases decreases proportionally. This becomes important when gases are trapped in various cavities. During compression of the patient, if there is air trapped within the body cavity, the volume will contract and may alleviate some clinical conditions. When the patient is decompressed, the trapped gas will expand and may cause complications. Now we'll look at the physiology. Just to brush, we know that oxygen is carried the blood in 2 main ways, hemoglobin and plasma. Hemoglobin is the main mode of transport, while plasma only carries a minute amount of oxygen. We usually consider oxygen as a requirement for the aerobic generation of ATP in the Krebs cycle, and so for all normal energy requiring processes in cells. Oxygen accepts the electrons that are passed down the cytochrome chain in mitochondria and is then chemically reduced to water. Oxygen is delivered at high partial pressure in hyperbaric chamber, is probably usefully seen as a drug with dose-response relationship and adverse effects that are not seen at partial pressures below 1 atmosphere. There are 2 main mechanisms of hyperbaric oxygen therapy. These include hyperoxygenation and decreasing bubble size. Hyperoxygenation results in an increase in dissolved oxygen in plasma as a result of increased partial pressure of arterial oxygen. This applies Henry's law, and it aids with the management of crush injury, compartment syndrome, flap salvage, and acute blood loss anemia. Decreasing bubble size applies Boyle's law. High oxygen intake saturates the blood plasma with oxygen. Volume of bubble decreases directly in proportion to increase in pressure. And this is the primary mechanism at work in management of decompression sicknesses and arterial gas embolism. There are secondary mechanisms of action. These include vasoconstriction, angiogenesis, fibroblast proliferation, leukocyte oxidative killing, toxin inhibition, and antibiotic synergy. Now we look at vasoconstriction. Hyperoxia in normal tissues causes vasoconstriction, which reduces post-traumatic tissue edema. Vasoconstriction, however, does not cause hypoxia, as this is more than compensated by the increased plasma oxygen content and microvascular blood flow. Collagen formation. Oxygen is vital for hydroxylation of lysine and proline residues during collagen synthesis. Also vital for the cross-linking and maturation of collagen, which is required for strong wound healing. When there's lack of oxygen, this can be corrected with hyperbaric oxygen therapy, and this leads to the adequate amount of mature collagen formation. Angiogenesis. Hypoxia is a vital stimulant for angiogenesis, but development of adequate capillary networks require adequate amount of tissue oxygen concentration. This, along with fibroblastic proliferation, leads to increased neurovascularization. Now we'll have a look at hypoxia. This is a pathological condition in which the body as a whole or a region of the body is deprived of adequate oxygen supply. Hypoxia is usually, we used to confuse hypoxia with hypoxemia, but they are different, and we can see where hypoxia, as stated before, is a reduction of oxygen supply at the tissue level. It is not measured directly by a laboratory value. It is caused by an inadequate supply of oxygen, which is due to the reduction of partial pressure of oxygen. Hypoxemia is a condition where arterial oxygen tension or partial pressure of oxygen is between 80 and 100 millimeter mercury. Patients will also experience hypoxia. Generalized hypoxia occurs in healthy persons when they ascend high altitude. This causes conditions such as high altitude pulmonary edema and high altitude cerebral edema. Hypoxia also occurs in healthy individuals when they breathe a mixture of gases with low oxygen content. For example, while diving underwater, especially when using closed-circuit rebreather systems that control the amount of oxygen that is supplied in the air. Mechanism of hypoxia. Hypoxia extends beyond the local wound environment. Reactive oxygen species are produced, including oxygen-free radicals. These cause vasoconstriction followed by vasodilation, endothelial cell damage and release of prostaglandins, pro-inflammatory cytokines, and nitric oxide from vascular endothelium occurs. Circulation is further compromised with compound injury, and in massive injury, the release of inflammatory cytokines and free radicals escape the normal regulatory mechanism and can lead to multiple organ failure. Therefore, a long and catastrophic chain of events can be initiated by oxygen deprivation. Hyperbaric oxygen exerts both direct and indirect effects on bacteria. Direct bactericidal and bacteriostatic effects occur through the generation of free radicals. This free radical oxidizes proteins and membrane lipids. It damages DNA and inhibits metabolic functions essential for the growth of organisms. Significant reduction in killing capacity of leukocytes occur when the tissue PO2 falls below 30 millimeter mercuries. In infected and traumatized tissue, they have a partial pressure below this, making them more susceptible to infection due to decreasing neutrophil activity. Indirect effects of hyperbaric oxygen in killing Indirect effects of hyperbaric oxygen in bacteria killing is through improving leukocyte functions. Neutrophils require oxygen as a substrate for microbial killing after phagocytosis occurs. The physiological and biochemical effects of hyperoxia. There is suppression of alpha toxin production by Clostridium perfringens. There is improved leukocyte killing activity, vasoconstriction in normal blood vessels, decreased post-traumatic tissue edema. There is promotion of fibroblasts, proliferation and collagen formation, angiogenesis in wounds, flaps, and irrigated tissues. There's also reduced half-life of carboxyhemoglobin, improved dissociation of carbon monoxide from cytochrome C oxidase, and prevention of neural injury in carbon monoxide poisoning. Now, clinical applications. Hyperoxygenation can be applied to carbon monoxide poisoning, central retinal artery occlusion, crush injuries, compromised grafts and flaps, severe blood loss, anemia. Decreased gas bubble size can be applied to air or gas embolism. Vasoconstriction, as stated before, can be applied to crush injury, compartment syndrome, or thermal burns. Angiogenesis and fibroblast proliferation can both be applied to problem wounds and delayed irrigation injury. Leukocyte oxidative killing can be applied to necrotizing soft tissue infection, refractory osteomyelitis, and problem wounds. Reduces intravascular leukocyte adherence and reduces lipid peroxidation can also be applied to crush injury or compartment syndrome. Toxin inhibition can be applied to Clostridial myonecrosis, and antibiotic synergy can be applied to necrotizing soft tissue infections. Additionally, hyperbaric oxygen therapy can be applied to sudden deafness, surgery and implant in irrigated tissue, stage 4 neuroblastoma, post-anoxic encephalopathy, and limb replantation. Now, the types of chambers. There are two main types, the monoplace and the multiplace. Monoplaces are small and designed to accommodate only one adult individual, usually in a supine or semi-recumbent position. Pressure capability of 3 ATA and compressed with 100% oxygen. There are advantages and disadvantages of the monoplace chamber. Advantages include cost efficiency, delivery of hyperbaric oxygen, no risk of decompression sicknesses, portable, less space, less equipment, no risk of iatrogenic decompression sicknesses in patients or staff. Some disadvantages include relative patient isolation, associated fire hazard, inability to use certain diagnostic equipment, and limited access to the patient. For multi-place units, these can accommodate 2 to 18 or more patients at a time, These incorporate a minimum of 6 ATA. Advantages include constant patient attendance and evaluation. Multiple patients can be treated per session. There's greater working pressure and a reduced risk of fire. There's also more room, which allows for medical personnel. Disadvantages include higher capitalization requirements, risk of cross-infection when wounds are treated, major space is required, and it has higher operating costs. Dosage and delivery. All regimens use 100% oxygen. Pressures are variable. Mostly used is 2.4 ATM. 4 ATM induces seizures. Treatment time varies from 1 hour to 2 hours. And we recommend that treatment be for 5 days a week. Contraindications. Now, untreated pneumothorax is a contraindication because of the gas emboli and the tension pneumothorax. A thoracostomy is used to treat this condition prior to hyperbaric therapy. Bleomycin, which causes interstitial pneumonitis, there is no treatment until the medication is finished. For cisplatin, this causes impaired wound healing, and there is also no treatment until the medication is finished. Medications like disulfiram, doxorubicin, and sulfamylon, these medications are discontinued and before hyperbaric treatment can proceed. There are relative contraindications such as upper respiratory tract infection, asthma, pregnancy, claustrophobia, seizure disorder, and hypothermia. When preparing for hyperbaric oxygen therapy, we have to take in account certain factors. The first of which is the medication. We'll take a full history, we'll take a full drug history from the patient, and there are certain medications that are not compatible with hyperbaric oxygen therapy, some of which we just discussed. Others include high doses of prednisone, morphine, alcohol, or insulin within 8-hour treatment. Persons with cold and flu-like symptoms will not be helped by hyperbaric oxygen therapy. We usually advise that the treatment be postponed until the symptoms subside. Hyperbaric oxygen therapy will not be effective in persons who smoke. To receive maximum benefit from hyperbaric oxygen therapy, patients are encouraged to discontinue smoking because smoking causes blood vessels to constrict. This decreases the blood and oxygen supply to tissue, counteracting the benefits of hyperbaric oxygen therapy. Cosmetics, oil or alcohol based are not allowed in the chamber due to the risk of fire hazards. Clothing particles containing nylon and polyester are not advised to be worn in the chamber. Watches are also not advised to be worn because the high pressure can cause it to break. Negative effects after therapy. Cracking sensation in the air between treatments is noted for some patients. This is because there's a difference between pressure between the middle ear and the chamber atmosphere. We usually advise patients to hold their nose and try to blow through it. This will help to clear the airway. There's also feeling of lightheadedness for a few minutes immediately after the treatment. There are potential complications of hyperbaric oxygen therapy, though these are rare. These include oxygen toxicity, which presents as seizures, dry cough, chest pain, or burning. There are visual refraction changes which are temporary and only last during the treatment session. And some of these changes include cataract and progressive myopia. Barotrauma can be noted in the ears, sinus, lung, and tooth cavities. In the midst of the coronavirus pandemic and in the dilemma of hyperbaric oxygen therapy, if it can reverse the pulmonary hypoxia, which is the main cause of death in patients with COVID-19. So Dr. Zhang, he conducted a study in Wuhan where 5 severe cases of COVID-19 patients were treated with hyperbaric oxygen therapy. They received treatment at a pressure of 1.6 ATA for 120 minutes for 5 days a week. Dr. Zhang promotes the use of hyperbaric oxygen therapy for critically ill patients efficiency in treatment. It reduces the pressure on health personnel and diminishes the risk of infection. It also decreases the mortality rate of critically ill patients. As evidence, it presents a successful treatment of 5 patients, 2 of which were critical and 3 were severe. It was observed that there was quick relief of hypoxia symptoms and quick correction of hypoxemia. For the quick relief of hypoxia symptoms, after the first session, dyspnea and chest pain were reduced. After the second session, symptoms basically decreased, the respiratory rate decreased, and they were swollen. For quick correction of hypoxemia, a blood sample from each patient was analyzed at the beginning of the session. They all showed low oxygen saturation. At the end of the session, the low saturation was completely reversed. From the fifth treatment session, oxygen saturation was greater than 95% in all patients. Dr. Zhang suggests that hyperbaric oxygen therapy is mechanical ventilation. This is because it has a higher oxygenation index and greater access to the cells to reduce inflammation since oxygen is diluted in plasma. Oxygen at higher pressures, a greater range of gas diffusion. This allows the thickening of tissues to be overcome due to inflammation and fibrosis of the lung. It was reported that there was significant reduction in pulmonary hypoxia from the start, with improvement at day 5 of the treatment. And this was seen on pulmonary computed tomography images. Dr. Zhang concluded that hyperbaric oxygen therapy in the treatment of pulmonary hypoxia is safe and superior compared to other methods, such as mechanical ventilation and ECMO for pulmonary oxygenation. In conclusion, we can see that hyperbaric oxygen therapy was started to treat decompression illnesses, but over time, its scope has gradually increased and it is now being used to treat a wide vast of conditions. The therapeutic effect is related to elevated partial pressure in the partial oxygen pressure in the tissues. This concludes my presentation.
Thank you very much, Ms. Hudson, for that presentation. Really, it has come a long, hyperbaric oxygen has really come a long way. I always knew it was valuable for decompression, but I wasn't aware of all these other benefits. And we do thank you for sharing that with us. And thanks Samaritan Cardiovascular Services for sponsoring your talk. Thanks very much. We're going to move right on to our final presentation for the afternoon. As you know, whenever the Caribbean College of Family Physicians has a conference, we always like to include a presentation by a family physician, appropriately trained and experienced person who can add value to the program. And one such person is certainly Dr. Aldyth. Say a few words about her. So I have to mention that. She is a university graduate. I see the primary care, general practice. Caribbean politicians. She has been a member of CCFP, barely a toddler at that time, obviously. She is our immediate past president of the Jamaica chapter, and she has many integral roles in CCFP Jamaica, CCFP regionals, and also the Medical Association of Jamaica, where we know she's the chair of the insurance committee, which has been doing great work in our relationships with the insurance companies. She has done a number of courses, including neurolinguistic programming, and she is very active also in the Jamaica Cancer Society, specifically the tobacco prevention program. Dr. Buckland has agreed to share with us an introduction of an example of a dementia action plan that we can use in our day-to-day practices as general practitioners and family physicians. So I'll ask you to welcome Dr. Buckland at this time. Sure. Yes. You're welcome.
Hello. Thank you so much for the kind words that you said, Aileen. I remember quite fondly our days at Wilmer's, and also when I went to the Golden Age home, you were there to guide us on how to do elder care. I'm Aldyth Buckland. I'm Aldyth Buckland now. I was Aldyth Buckland yesterday, and I think and hope that I will be Aldyth Buckland tomorrow. I have the pleasure to introduce an example of dementia action plan for practices. In every plan, it is important to do a brain health assessment. And I invite you to go to brainhealthassessment.com and check it out. At this site, you'll get something I would call like an executive checkup of the brain. It's so quick, it's online, real time. You'll get a brain fit score. It will look at areas of your brain health, sleep, memory, executive function, inner peace, mood, flexible thinking, and so on. And recommendations to optimize your brain fit score. I like to play with this quite often. So once you go into it and you find that you really like it, you may want to share it with your patients because it really is easy and it will give you an idea about how their brain health is and how they can increase their brain fit score. Apart from doing a brain health assessment in our planning, we want to learn techniques on training our brain. The two previous speakers, Dr. Govia and Dr. Barnaby, they have mentioned how important it is to take care of the brain. And we need to take time for ourselves. We need to chill. We are really, really busy people, and we need to take time and chill with a journal in the morning. Just quiet time and think. One thing I can get excited about today is, and why are we doing this? Because we're training our brain, the thoughts, the feelings, and the behavior. And I would know that today was a great success if at the end of the day I did all of these things. Do this in the morning. Focus. It's helping the focus part of our brain. And in the evening, you come home after a long day and you sit down and reflect. A moment that I really appreciated today was, and think about what that was and give thanks. You may also think a situation or task I handled well today was, and you may even reflect about a particular patient, person's family, what that person means to that family, what the person means to you. Why? Because the person lives, loves, and matters. Sometimes you may feel really stretched, you may feel as if you're going to be popped out of your comfort zone, and it's okay because once you know that just as you live, you love, and you matter, your patient who has dementia or is showing signs of evolving into that way also lives, loves, and matters, and have people who live and love and matter to them. So today, I'm going to share with you something which is an example of dementia prevention, intervention, and care action plan. Dementia is the single most biggest challenge in the 21st century to healthcare and social care. A lot of investigations have gone on, and many experts have been doing research on this to find out what works and what does not work. One such team of experts is known as the Lancet Commission. And they presented a new life course model showing potentially modifiable and non-modifiable risk factors for dementia. They said that if certain risks are eliminated, then there is a potential percentage reduction in new cases of dementia. Potentially modifiable risk factors along the life course delay or prevent about a third of dementia cases. That is absolutely fascinating. In early life, they found that less education was a significant risk factor. Midlife, hearing loss, hypertension, and obesity. I call that HHO, hearing loss, hypertension, and obesity. And in late life, the modifiable factors, which when eliminated will decrease the risk of dementia, are smoking, depression, physical inactivity, social isolation, and diabetes. I remember it by doing SD, I like to hear things, SD, PISID, smoking, depression, physical inactivity, social isolation, and diabetes. Pay attention because I'm going to test you. So this commission has some key messages for us. They said that the number of people with dementia is increasing globally. And what this means is that we are going to be seeing more people with dementia presenting to us. They also said to us that we need to be ambitious about prevention. Recommend active treatment for hypertension in middle age and older persons without dementia. Why? To reduce dementia incidence. Intervention for other risk factors, including more childhood education, exercise, maintaining social engagement, reducing smoking, management of hearing loss, depression, diabetes, and obesity might have the potential to delay or prevent a third of dementia cases. And guess what, my friends? This is all up our street. Quite doable now, we can do this. The next two are caring. So the first two are caring were the number of people with dementia and be ambitious about prevention. The next two, remember they went into the R2x2, treat cognitive symptoms and individualize dementia care. Treat cognitive symptoms to maximize cognition. People with Alzheimer's disease or dementia with Lewy bodies should be offered cholinesterase inhibitors at all stages, or memantine for severe dementia. Cholinesterase inhibitors are not effective in mild cognitive impairment. Individualized dementia care. Good dementia care spans medical, social, and supportive care. It should be tailored to unique individual and cultural needs. It should be tailored to the person's preferences. It should be tailored to priorities and should incorporate support for family carers. The Lancet commissioners also told us that we need to care for family carers and we need to plan for the future. Family carers are at high risk for depression. Effective interventions, including strategies for relatives or resources for enhancing caregiver health intervention, reduce the risk of depression, treat the symptoms, and should be made available. Planning for the future, people with dementia and their families value discussions about the future and decisions about possible alternatives to make decisions. These are things we want to bring up in our discussions with them. Clinicians should consider capacity to make different types of decisions at diagnosis. The next two coming up as key messages are protect people with dementia and manage neuropsychiatric symptoms. Protect people with dementia. Now, I want you to imagine when I speak about this, to think of a person that you've seen on the street who has dementia. You think about somebody in the family that you've gone and done a house visit on. You think about somebody who's come to your office. You bring in the caregiver. Bring them up in your mind right now as I read this to you. Protect people with dementia. People with dementia and society require protection from possible risk factors of the condition, including self-neglect, vulnerability, including exploitation, managing money, driving or using weapons. Sometimes people get knocked up for this. Risk assessment at all stages of the disease is essential, but it should be balanced against the person's right to autonomy. So that is protecting the people with dementia. Manage neuropsychiatric symptoms. Management of neuropsychiatric symptoms of dementia include agitation, low mood, or psychosis. This management is usually psychological, social, and environmental. Sometimes they just need to go out and smell roses. Sometimes they just need to be among friends and family. They just need to do something different. Pharmacological management will be reserved for individuals with more severe symptoms. And the last two that they Lancet commissioners want to tell us about consider end of life and technology. A third of older people die with dementia. A third of older people die with dementia. So it is essential that professionals working in end-life care consider whether a person has dementia, because they might be unable to make decisions about their care and treatment or express their needs and wishes. As for technology, technological interventions have the potential to improve care delivery, but should not replace social contact. Acting now on dementia prevention, intervention, and care. That's the name of the article. This article is in the Lancet, December 16, 2017. They said, acting now on dementia prevention, intervention, and care will vastly improve living and dying for individuals with dementia and their families, and doing so will transform the future for society. I suggest that you read this article. It is fantastic. These are 24 international experts who have brought consolidated material, and they have told us what is effective and what isn't, and they have given key messages to us. And I have some questions for you. You ready? Would a brain health assessment on yourself or on a patient done timely and repeatedly help in evaluation and monitoring of brain fitness? And I'm not talking about anything. I'm just talking about for regular people. Because remember, the Lancet Commission said you want to identify risk factors along the life course. So you're going to have people who are asymptomatic, who have nothing at all. You want to find out changes in their mood. They could be having a bad day or so, but just doing this will actually help them to refocus. And then the site I showed you, brainassessment.com, you can tell the patient, you go to this site and check on yourself from time to time if you're feeling a certain way. Even once a month, do a check on yourself. And then they will get an appreciation of your brain awareness. They will get to love their brain. Remember the brainassessment.com, I liken it to the executive. You know, when you do an executive function, an executive test, I think this is like an executive test for the brain. But it brings up the awareness to improve, to appreciate and love the brain, to take care of it, like how we want to take care of how we look and so on. Next one. Oh, so you never answered that question. Would a brain health assessment on yourself or on patient done timely and repeatedly help in evaluation and monitoring of brain fitness? I think so. I really think so. I like to do this from time to time. And sometimes I may just actually put in things that I am not to see what happens. And I get quite interesting answers, and the recommendations are quite point on. This assessment tool was written by, was designed by Dr. Daniel Ahmed, who's a psychiatrist. And this is his pet. This is special. He just loves this area. So look at it. Brain healthassessment.com. Second question. Is dementia prevention, intervention, and care? That's the name of the article. Is it an example of a dementia action plan? You better say yes. Good. Okay. Next, reduction of modifiable risk factors. Reduction of modifiable risk factors may reduce dementia cases by 1/3. So, what are the modifiable risk factors in childhood? Less education, further aging. Less education is a modifiable risk factor, and it is so significant. It is 8%, and if this risk is eliminated, then 8% risk reduction of dementia. What about in midlife? What are the modifiable risk factors in midlife? HHO, what is that? Look at me, look at me. What am I pointing to? What does this do? I'm pointing to my ears. H is hearing loss. That's 9%. can't hear, you can't stimulate your brain. That is significant loss for neurological stimulation, and that the Lancet commissioners said we need to fix that for the patient. We want, because suppose it could even wax in the ears. Something that is easy, or we just send them on so that they can get a proper hearing aid, you know? But we need to fix certain things. So in midlife, it is HHO. Hearing loss, what's the other H? Very good, and O. Obesity, very good. HHO, hearing loss, hypertension, obesity. And what are the modifiable risk factors in late life? Smoke, send me your point on, send me. 5%. Everybody gives Semi a clap. Smoking, very good. And we can help the patients through this, all right? Because we have motivation and interviewing skills, and we just walk along with the patient, all right? Because they're smoking for a reason. Smoking is one. What other modifiable risk factors we have? That's S, D. Let's do it in order. S, D. What is D? The D stands for yes, depression. Good, good, good. And then we have PI and SI. PI, SI. What does that stand for? Physically inactive and social isolation. And then the last D is diabetes. So I say SD, PI, SI, D. Let's do that together. So that is, what does that stand for? Smoking, this is later. Smoking, depression, physical inactivity, PI, SI, social isolation, and diabetes. So, early life, what is a modifiable risk factor? Less education. So, what, and in midlife, what is HHO? What is it? Come, quick. Hearing loss, good. Hypertension, good, quick. Oh, your brains are clicking, nice. And then late life, what is it? SD, smoking and depression. PI, SI, what is that? So because you got, remember, we want to actually get our patients moving, all right? Physical inactivity and social isolation. So they've got to be out with other people, or people have to come and sit them. And diabetes, very good. So I think you got that. So, one last question. As we, our patients, families, and carers live, love, and matter, can we work together on a dementia action plan for practices? I think we can, and we have got such valuable tips from the other presenters. We can just put everything together, and then write out something, and then put it on the CCFP website. I think we have a good start. And so, thank you for being on this journey with me as I share an example of a dementia action plan.
Thank you very much, Dr. Buckland. As usual, a well-researched, passionate, practical presentation. Every time you present, we see your passion in what you do, and the things you present are always so relevant to what we do in practice. We are winding down now. I'm glad to see we still have almost 200. A few have gone off to have their lunch, but we still have 179 people with us online, and those of us in the room. So before I call on Dr. Ananuju to do the formal vote of thanks, just want to give a little thank you token to Dr. Buckland for her presentation. Dr. Buckland, thank you for the presentation today, but also for all the work that you have done over the years with Caribbean College. We do appreciate your ongoing support, and just a little token for today. Over the last 3 months, with the advent of COVID, we have had to move very quickly to using the technology to do our seminars. And there is one person who has really helped us a lot over these 3 months, not just on the day of the seminar, but in preparing for the seminars, giving us advice on technology, guiding us through. And we do want to say a special thanks to Mr. David Miguel. I just want to make a small presentation to him.
Small.
David, you've really come to our rescue and really helped us to move forward into the technological age. We do thank you for your help and guidance over these 3 months and look forward to your continued working with us. Thank you. Okay, thank you very much. Wouldn't have been possible to do these seminars without his help. I'm going to call now on Dr. Ananushu, the president of CCFP Jamaica chapter, to do the formal vote of thanks for the session today. Dr. Ananushu.
Thank you very much.
Our host today, Mr. David Miguel, specially invited guests, distinguished colleagues, locally, regionally, and worldwide. Friends, ladies, and gentlemen, good afternoon to you all. It has been an awesome day, and we thank God for such a day. Thanks to the Caribbean College of Family Physicians, Jamaican chapter, for providing such eloquent and knowledgeable speakers from our very own region. This particular meeting was initially planned by Dr. Julian and Dr. Aldyth Buckland, along with all the members. They were supported, obviously, by all the members of the planning board of the college. I have to especially thank them because this meeting was moved from March because of COVID. And every time it was to come, it was moved forward again. Finally, we have been able to present it today, and we don't want to forget people who initiated even the topics. Both initially it was Dr. William Brown and Dr. Aldyth Buckland, and we all supported them. Unfortunately, one of the presenters lost a very close family member and was not able to make it. Just suddenly, we contacted Dr. Govia and Dr. Barnaby, call it about 2 weeks ago. And the level of their preparation, I know is their field, but even with that, with the amount of work we have as doctors, I thought that they put in a lot of work. So we were quite happy that this came out. Of course, it was real as it did. So Dr. Buckland, Dr. A.L.S. Standard Goldstein, Dr. William Brown, and all the members of the planning committee. Before I go further, I want to say thank you all for the effort that you put in behind the scene. Other people will not see this, but we know. You will agree with me that it was a great day And in my own judgment, I would say it was lovely day indeed. So the moderators, Dr. William Brown and Dr. Ellen Standard Golson, we thank you for so ably guiding the proceedings and ensuring that as much as possible we kept within our time limits. I'm sure if it were not for you, we'd still be here continuing presentations. To our speakers, Dr. Lorraine Barnaby, Dr. Ishtar Govia, Julian McKoy Davis, Dr. Mark Taylor, Ms. Latifah Hudson, and Dr. Aldyth Buckland. We thank you all very much. The presentations were excellent. To my mind, they were insightful. And as Ellen said, they were dynamic, particularly Aldyth Buckland, because that is just her personality. And so I don't know if I will say it's a part of the presentation or it's a part of Aldyth, but they were dynamic and they were well delivered. We could not have demanded more. We thank you for the in-depth knowledge that you have shared with us, and we hope to use this knowledge that we have garnered to improve the care of our patients. To the Secretariat, headed by Mrs. Lynn Ayers-Thompson, we thank you for always working behind the scene to ensure that all goes well. To say very little, to the technical support team, headed by Mr. David Miguel. I spoke with David Miguel. I'm not somebody, even if I'm working from dawn to dusk, you will not know that because personality, I'm just opposite of Aldyth. So, but he will tell you how often I disturb him. As most times, sometimes he's still at school dealing with students, either at the university or at New Tech. And he just finished a presentation with the Association of General Practitioners last week. He was very busy. I gave him that week break so as not to put him into depression or people bothering him. As soon as he dropped that job, by the next Monday I was on him. I remember I called him, he was on his way home. He told me he called me back, I was waiting long. I didn't hear from him, I took up the telephone. I did not stop bothering until he gave me an answer. And within a short time, I was able to liaise with all the speakers. And indeed, people don't know that what he's doing, but indeed it's a lot of work. And on behalf of the college, I must say special thank you. We just gave a little basket. That's just a token. But we don't have any other way of expressing our gratitude. But we thank you very much. And he always providing us with dependable and world-class technical support. And today, this was so throughout the duration of the webinar. To our sponsors, it takes cash to care. We are truly grateful and thank our sponsors. Medimeds Jamaica Limited, we heard that they have moved from Ripon Road North to Balmoral Avenue, number 21, just before you get to number 23 Institute. So for those of you who don't know, let me remind you, they told us twice at least. H2K Canada and Samaritan Cardiovascular Services. We thank you for the sponsorship and we look forward to continued partnership. We thank Alhambra Inn for always opening their doors and providing a safe, convenient space with just the right ambience to make for a fitting venue. This is COVID time. They don't make us feel COVID. They make us feel home. We thank Alhambra Inn very much. To you, the audience, those who are here, I think we almost have 200 persons online and on the hub. We thank you for being such an audience, attentive and interactive audience. What a great audience you have been. Despite the geographical distances between us, we still remain virtually connected as a united medical family. We thank you again, and God bless you all. And those who are here, we wish you God's guidance and home safely. And those who are at home, we pray for your safe and continued staying well for the period of COVID. I think as a nation, we are grateful that COVID has not swept away most of us. And in fact, if any, very few. And we thank you, the Ministry of Health, everybody, for all the effort that everybody has put together. Although there are few people here, I think it's not just one somebody, it's a host of people. So on behalf of the Association of the Canadian College of Family Physicians, I say a warm thank you and God bless you once again. Thanks.
Thank you, Dr. Onanuju. And with those words, we'll end the session today. And thank you all for spending the time with us. And we know it would have been beneficial to us all. Have a good Sunday evening.